Our planet never ceases to amaze us. The best is always waiting to be discovered. Every corner hides unseen treasures. In unknown places, treasures of breathtaking beauty that leave you spellbound. Where you can reach new heights and feel on top of the world. Run your fingers along the relics of a rich past. Discover new places where you can leave your mark. Be the first to witness a land of fascinating journeys. Where in the world could this be? Saudi. Welcome to Arabia. Get your visa now.
COVID-19 has challenged the capabilities of healthcare systems around the world. The virus shows little indication of slowing down. So digital health innovation has become even more imperative. The pandemic has accelerated demand for technological solutions. Tracking, monitoring and predicting coronavirus outbreaks. Innovations save lives. Through telemedicine, analysing health data and robotic patient care, all while artificial intelligence plays a vital role in developing drugs and vaccines. We must build upon this momentum and achieve unprecedented advancements in digital health. We must advocate for digital health solutions as a core part of countries' recovery plans. Global collaboration is our best chance for success. Hosted by the Kingdom of Saudi Arabia as part of International Conferences Programme, honouring Saudi's G20 presidency year. The Riyadh Global Digital Health Summit is bringing together leaders, decision makers and pioneers with the ambition to realise the greatest opportunities of this century. Join us as we create the Riyadh Declaration on the role of digital health, an actionable roadmap to enable the international healthcare systems to jointly contend with global pandemics, one of the most pressing challenges of our time.
Welcome everyone to the Riyadh Global Digital Health Summit. My name is Wa'am al-Dakhil, a Saudi journalist, and it's a great pleasure for me to be here today. Over the course of today and tomorrow, this event will bring together leaders of healthcare systems, public health, digital health, academic institutions, and businesses in order to discuss the vital role of digital health in the fighting against current and future pandemics. Thank you for joining us. In addition to hearing from excellent speakers, we want to be hearing from you, the audience. On the right side of your screen, you will find the Q&A panel. You will have the opportunity to engage throughout the event by posting questions and voting on polling questions. These interactions will take place at different times during the event, mainly before each session. So don't worry about the technical side, we will guide you through it. To kick off this event, it's my honor to introduce our host. His Excellency Dr. Bandar Algnawi is the Chief Executive Officer of the Ministry of National Guard Health Affairs, the President of King Saud bin Abdulaziz University for Health Sciences, and the President of the Riyadh Global Digital Health Summit. Please welcome His Excellency Dr. Bandar Algnawi. تفضل.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين. I would like to welcome you all to Riyadh, Saudi Arabia. I will start with a quick speech in Arabic, then in English. It is a great pleasure to really be here with you today and welcome every one of you virtually to this very important scientific summit. الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين، أصحاب المعالي والسعادة، السادة المتحدثين الدوليين ومحليين، ضيوفنا الكرام، السلام عليكم ورحمة الله وبركاته. من الرياض عاصمة المملكة العربية السعودية في سنة الرئاسة لدول مجموعة ال20، أرحب بكم جميعا في حفل إطلاق قمة الرياض العالمية للصحة الرقمية والمؤتمر العلمي المصاحب لهذه القمة بعنوان الشراكات الاستراتيجية للصحة الرقمية لمكافحة الأوبئة، والذي تنظمه وزارة الحرس الوطني الشؤون الصحية بالتعاون مع الأمانة السعودية بمجموعة ال20 والمركز السعودي للشراكات الاستراتيجية الدولية كأحد برامج المؤتمرات الدولية على هامش فعاليات السنة الرئاسية للمملكة العربية السعودية لمجموعة دول ال20 للعام 2020. وبهذه المناسبة يشرفني أن أرفع لمقام سيدي خادم الحرمين الشريفين الملك سلمان بن عبد العزيز ولسيدي صاحب السمو الملكي الأمير محمد بن سلمان بن عبد العزيز ولي العهد نائب رئيس مجلس الوزراء وزير الدفاع حفظهم الله جميعا أصدق التهاني والتبريكات على نجاح اجتماع القمة الاستثنائية التي انعقدت بدعوة من المقام الكريم في 26 من مارس الماضي، وعبرت خلالها الدول الأعضاء عن التزامها بالعمل ضمن جبهة موحدة لمكافحة وباء كوفيد-19. وإنما تحقق ولله الحمد من أصداء واسعة ومؤثرة لهذه القمة الاستثنائية على صناع القرارات الصحية والاقتصادية حول العالم، يأتي مؤكدا على قيادة وريادة المملكة في هذه السنة الرئاسية رغم الظروف العالمية التي نعيشها في العام 2020 جراء تفشي هذه الجائحة. كما يسرني كذلك أن أرفع لصاحب السمو الملكي الأمير عبد الله بن بندر بن عبد العزيز وزير الحرس الوطني خالص الشكر والامتنان والعرفان على دعمه للشؤون الصحية بوزارة الحرس الوطني تنظيم هذا المؤتمر بهذه الصورة المشرفة والتي عكست مدى التطور الرقمي الصحي لوطننا الغالي على المستوى الدولي، وتسليط الضوء على جهود المملكة المتميزة في التصدي لهذه الجائحة والإجراءات الاستباقية والاحترازية التي اتخذتها حفاظاً على أرواح المواطنين والمقيمين على أرض وطننا الطاهر. إنما قامت به حكومتنا الرشيدة في مكافحة الجائحة وما اتخذته من قرارات حكيمة وما وفرته من دعم للسيطرة على تداعيات هذه الجائحة، ودور المملكة الريادي عالميا كان له بالغ الأثر في التصدي لهذا الوباء، حيث أصبحت هذه الجهود مثالا يحتذى به ومنهجا يتبع. وخير شاهد ما تحقق مؤخرا بفضل الله تعالى وتوفيقه من إدارة استثنائية وتقنية لحج هذا العام 1441 وخلوه من الإصابات مما يدعو للاعتزاز والفخر، حيث جاء هذا النجاح المتميز استكمالا لسلسلة النجاحات في التصدي لهذه الجائحة في وطننا الغالي. ويسعدني أن أتقدم بالشكر لأخي معالي الدكتور توفيق بن فوزان الربيعة وزير الصحة على دعمه لإنجاح فعاليات هذا المنتدى. ولا يفوتني أن أتقدم بالشكر على الجهود الكبيرة في تنظيم هذا الحدث المتميز والتي قامت به الأمانة السعودية لمجموعة ال20 وعلى رأسها معالي أخي الدكتور فهد بن عبد الله التونسي المستشار بالديوان الملكي الأمين العام للأمانة السعودية لمجموعة ال20. والشكر موصول لأخي معالي الدكتور فيصل بن حمد الصقير الرئيس التنفيذي للمركز السعودي للشراكات الاستراتيجية الدولية على ما قدمه المركز من دعم كبير واهتمام الشخصي من خلال بناء الشراكات الاستراتيجية في مختلف الدول والإعمال على إنجاح هذه القمة العالمية، والتي ولله الحمد يتم انعقادها بشكل افتراضي عن بعد بما يتناسب مع المرحلة الحالية في تفشي هذه الجائحة العالمية. كما أتوجه بالشكر لضيوفنا الكرام من أصحاب المعالي والسعادة رؤساء الجلسات والمتحدثين من داخل المملكة وخارجها على تلبية الدعوة ومشاركتنا فعاليات هذا التجمع العلمي المتميز، والشكر لكل المسجلين عبر المنصة الإلكترونية لهذه القمة ولكل من ساهم في إنجاح هذه القمة العالمية والمؤتمر العلمي المصاحب لها، داعين المولى عز وجل بالتوفيق والسداد وأن يحقق هذا التجمع العلمي الأهداف المأمولة بما يخدم المستقبل الزاهر للرعاية الصحية الرقمية ومكافحة الأوبئة في جميع أنحاء العالم. والسلام عليكم ورحمة الله وبركاته. Excellencies, distinguished delegates, honorable speech, dear colleagues, ladies and gentlemen. From Riyadh, Saudi Arabia, it's a great honor and pleasure that I welcome you all to the Riyadh Global Digital Health Summit, the global strategic partnership in digital health to fight pandemic. We're absolutely delighted to host this unique conference, which we believe represents a groundbreaking and historic event to collaborate and address unprecedented global crisis. I would like to thank every one of you for taking the time to join us today. I'm thrilled to welcome you and welcome over 100,000 participants from 110 countries around the world. Wherever you are, I hope that one day I will be able to welcome you personally to Riyadh, where you are always welcome. COVID-19, of course, has changed all of our lives in an unexpected way. None of us have experienced anything of this scale and magnitude in our lifetimes. I don't think it is exaggerated to say that this is the worst human disaster in recent history. Every country, city, and individual has been affected by this coronavirus. Today, the stats report nearly 20 million infected people and well over 700,000 across the world of death. While we are in many ways that we don't see the virus, the damage it has caused and continues to damage is only too visible. We are currently engaged in a war against this virus, a war that has already resulted in loss of many lives. SARS-CoV-2 has caused a tremendous personal, social, and economic hardship. I'm sure that all of you agree with me that this pandemic has created and continues to create a deep and permanent scar. But as you know, every cloud has a silver lining. At this age of continuous connection and digitization, COVID-19 has opened up new opportunities for us to connect, learn, innovate, and think about how we can better fight communicable diseases. The response to this pandemic has required strong and unified global leadership, and any lessons that are learned should not be wasted. I believe COVID-19 has brought the importance of public health to the forefront as a critical global health security issue. In addition, digital health has played a crucial role in the fight against COVID-19. And now is the time to better leverage digital health to deliver global and unified approach for the current and future disease outbreaks. I believe digital health represents the very best of combining modern technologies, medicine, science, and innovation with data and public health to the benefit of the health and well-being of the humanity. A very powerful recent example, the Kingdom of Saudi Arabia has successfully managed the religious mass gathering for Hajj pilgrimage, despite the clear threats posed by this pandemic. This was achieved by advanced digital technology, reflecting the Kingdom leadership and its global role and responsibilities in taking strict public health precautions to ensure a healthy Hajj for all pilgrims and the international community as well. I would like to take this opportunity to thank and congratulate His Majesty King Salman bin Abdulaziz, the custodian of the two holy mosques, and His Royal Highness Crown Prince Mohammed bin Salman bin Abdulaziz for their leadership during this important time. This virtual event, organized by the Ministry of the National Guard, Health Affairs, the Saudi Center for International Strategic Partnership, and the Saudi G20 Secretariat, in collaboration with the Saudi Ministry of Health, brings together all relevant stakeholders to work together to discuss coronavirus pandemic through an enhanced digital public health leadership. You will hear from renowned scientists, clinicians, academicians, public health leaders, and health policy makers from all over the world. The organizing committee and the advisory board has selected carefully the most relevant topics to address, from digital epidemiology, pandemic prediction models, to communication and health policy. We aim to promote digital health technologies and their critical role in enabling public health solutions in the fight against pandemic across many domains, including monitoring, surveillance, detection, prevention, and mitigating the impact of the disease on health and care system delivery. We hope to foster responsible and well-governed use of data to fight pandemic. Just as importantly, to maintain the public health trust and best cybersecurity practices. I am overwhelmed by the amazing support from my colleagues all over the world, which was apparent from the very beginning of our preparation for today. I would particularly like to thank the organizing committee, the advisory board, chairs and co-chairs of the sessions, the speakers, and indeed every attendee. I conclude today by announcing that tomorrow, the summit recommendation will be announced as a declaration for the Riyadh digital health during pandemic. It will be chaired by His Excellency Dr. Tawfiq al-Rabi'a, Minister of Health, Saudi Arabia. Please join us tomorrow for this important session. Once more, welcome to Riyadh. Please enjoy this exceptional and timely session. Thank you very much.
Shukran, Dr. and Excellency Bandar. Good morning, good afternoon, good evening, everyone, from wherever you are in this small world. It is a pleasure to be here and it is from WHO perspective, we continue to focus on solidarity to fight the pandemic. Let's remember that this is not just a public health pandemic. It is not the COVID-19. It's not only a public health pandemic. It is economic. There's economic impact. There's a social impact in addition to the public health impact. And due to that, global multi-sector partnership and collaboration is key. Or in other words, we need stronger solidarity. But also, let's remember that the public health sector is not very advanced in the digitalization compared to sectors such as media, financial sector, insurance, education, and others. So we still have a long journey to ensure that the digitalization or the digital transformation of the healthcare sector is accelerated to make sure that as we go through this very first pandemic in the digital era, we actually leverage on those digital tools and digital solutions to bring about less suffering, less death, and really take advantage of the digital technologies to advance issues such as early surveillance systems, health system strengthens, in addition to vaccine therapeutics and diagnostics. At WHO, we have the Access for COVID tools, which is a global partnership, and we hope that all the global initiatives and collaborations and partnerships, they lead us into one specific outcome, which is an outcome where, first of all, we do better next time. Second of all, we minimize the impact on socioeconomic and health impact in current pandemic. And also we have to do better than what we do in, for instance, weather forecasting. We need to do better on disease surveillance systems to ensure that we are able to minimize the impact of this pandemic. Now, as we fight the pandemic, and as we go through preparedness, surveillance, response, and recovery, there are three areas that we need to make sure that at this stage, it needs to work hand in hand. So from one end, the public health security, where we see the work of public health response to COVID-19 at national, subnational, and global level. We need to also look at the digital solutions, both on epidemiology, but also on digital epidemiology, health data management, and all the issues that perhaps we've been not giving sufficient attention in the past to accelerate that, to make sure that we really succeed and we really minimize the impact to the whole world on diseases such as COVID-19. The third area is cybersecurity, ethics, and privacy. So a trusted ecosystem or trusted digital health ecosystem is key. So we hope that that collaboration, and at WHO we have the Global Digital Health Strategy, which is going through the approval of our member states. We build an ecosystem that is trustworthy, it's ethical, and it adheres to privacy issues. And I know it's easy to say, and it's a journey to get through, but nothing in this world, if we are determined, there's nothing in this world that can stop us from creating a safe, secure, and ethical digital health ecosystem that delivers public health impact and health outcomes, positive health outcomes, to ensure that we better manage diseases and pandemics such as this one. On public health security, of course, there's many countries and whole world, as Excellency Dr. Bandar mentioned. We're trying to bring innovation, we'll mobilize sectors to control case, suppress transmission, reduce mortality. So and we are learning the virus, the technologies, and the innovation that is needed to do that. On the digital side, the population and patient care in using digital solutions is key. And for that, we need to make sure that digital solutions are an integral part of public health response, not another silos. The public health and the healthcare sector has been working in silos for many, many years. I think it is time for us to bring the integral solutions, but also making sure that we create an interoperable ecosystem that really brings benefits and public health benefits, as well as positive health outcomes for the global community, especially using digital solutions. So we hope with the G20 presidency from Saudi Arabia, we can initiate that journey together with multiple stakeholders. Now, by preserving data privacy and security, it's key. We see health data as part of health data should benefit and enjoy similar principles as human rights, to ensure that on one end we protect the privacy, but on the other hand we also ensure that sharing data for benefit of health, to ensure that this principle of creating a donation as we donate organs in health and life science, but also ensuring that there's no abuse from monetization of data. We need to strike that balance where privacy, data security, and ethics work hand in hand and bring those needed benefits that we all want to see. With these, I want to just thank Excellency Dr. Bandar, but also thank all the participants that joined this global digital health summit to take this challenge of the new normal post-pandemic requires a new normal of working together. And that new normal of working together requires multi-sector partnership, requires every one of us, both private sector, public sector, academia, civil society, to the United Nations, to bring the best of us to really reduce the impact of the current pandemic, but also do way better next time. Thank you. Shukran.
Thank you, Dr. Bernardo Mariano, for such a rich presentation. Well, at this point, we would like to hear from the audience. So on your screen, you'll see two questions. First question, in your view, what are the main challenges facing the usage of digital epidemiology? Please take 30 seconds to fill in your answer and we'll collect your insights. So the second question is a polling question. On a scale from 1 to 5, how strongly do you agree with this statement? The global digital epidemiology system play an important role in early detection of pandemics. So 1, strongly disagree, 2, disagree, 3, neutral, 4, agree, and 5, strongly agree. We'll have the answers showing up in a bit. So as we can see, the majority actually strongly disagree that the global digital epidemiology systems play an important role in early detection of pandemics. So our first session will discuss more about the topic of digital epidemiology, broadly defined as epidemiology that uses digital methods from data collection to data analysis. To start this session, it's my pleasure to welcome the session chair. Welcome back, Dr. Bernardo Mariano.
Thank you. Greetings once again. It's a pleasure to chair the session together with my co-chair, Chiara, which will join in later. The focus of this section is digital epidemiology and how that can complement the public health response. I think the question of that I think the response that came up from the previous survey shows that in isolation, digital epidemiology cannot support, will not help the pandemic. But as an integral part of the public health response, that's where it can make a difference. We have seen innovation such as contact tracing, symptom checkers. In isolation, they do not add the value that we need to see them adding in the public health response. So we need to strengthen the public health response and then have those tools as an integral part of public health response. And I hope in this session, the distinguished speakers will be able to outline some examples of such scenarios where the digital solutions or the digital epidemiology supported the public health response as an integral part of it, and the value was added with that. At WHO, we've been actively engaged for decades with the ProMed, the GPHIN. All those were started in the early 90s to get surveillance data to monitor early detection. And as I said, we're still not doing well compared to, for instance, weather forecast. So we need to do way better. So there are challenges in the digital epidemiology or even infodemiology, where, because I said in early on, this is the first pandemic in a digital era, and that therefore the response requires both. Not one, not just the digital side, not just the public health side, but both. And there are challenges regarding data access, data sharing, privacy, and others. So I'm looking forward to hearing more from our distinguished speakers and colleagues that will be taking us through these and explore these emerging surveillance tools. And with that, I have the pleasure to introduce the first speaker, Dr. Anand Bahi, the ADG at WHO, to provide our presentation on this topic. Dr. Bahi, welcome to the stage.
Hello, Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Bernardo, for the great, for the kind introduction. I would like to start by congratulating the Kingdom of Saudi Arabia on its leadership during the G20 presidency, the G20 countries, and specifically the G20 Secretariat, for having a very strong vision about digital health even before the COVID outbreak, and making digital health a priority for during their presidency of the G20. I would also like to thank His Excellency Dr. Bandar Algnawi for inviting me, and for the organizing committee and the scientific committee for putting really a great program together. And I'd like to thank everybody around the globe who have logged in today for this specific summit. I'd like to start with my So as you can see, the communication revolution that took place over the past 20 years has been really significant, and two major outcomes came out of that. The first one is that digital communication has really overtaken the method how we communicate throughout the globe. And the numbers of people who have the ability and access to it have increased to billions of people around the world. And that has led to a major opportunity for us to utilize and capitalize on this type of data that now exists at the tip of our fingers. If we look at the next slide, which talks the definition of digital epidemiology, there were several definitions that existed in the literature. But if we go back to traditional epidemiology to start with, it is really the disease, the willingness and the aim to understand distribution of disease. So what happened, where, how, what were the interventions, what were their impacts? And in that type of study, we would be able to identify patterns of diseases, risk factors, the specific interventions. And as you can understand, for those who are on this webinar, is that this information is extremely important in a small global community today to keep the world safe. Digital epidemiology has the same aim, usually in the hands of epidemiologists, but utilizing tools that existed not for the sake of conducting epidemiological studies. However, they were there for other reasons. And epidemiologists today are seeing that there is a potential opportunity to utilize this data in identifying some of the different aspects that help us understand and conduct epidemiology. In my next slide, this is a study that was conducted between 2008 and 2018, where it assessed 109 different articles using digital data. And as you can see, it identified the most common data source being web search queries, followed by social media posts. And interestingly enough, the topic of domain of most prevalent in that specific study found that infectious diseases was the most common topic, followed by non-communicable diseases. Among the infectious diseases included in this paper that were found to be of priority were nothing other than major outbreaks: Ebola, MERS, SARS, and others. The next slide shows the life cycle of any epidemic or outbreak, if you will. This can range from a hospital-based outbreak to a major community outbreak. This is taken from one of the resources that we have in WHO. And as you can see, for us to be able to identify an outbreak, we need to be able to detect. And in the old epidemiological slides that I used to present, the sources of being able to detect an outbreak should come from multiple sources. The active surveillance done by experienced field public health individuals to news feeds, news medias, Twitter accounts. Even false news needs to be taken seriously, or suspected false news needs to be taken seriously to be able to verify and identify the truth behind such clusters or outbreaks. So the detection part is extremely important. After that, monitoring a specific cluster that might flourish into a local national outbreak or a regional outbreak, or to what we see today as a pandemic. Then it goes through an intervention period where the tools of public health interventions are put in place and assessed at the same time. And then as the outbreak wanes down, hopefully, there needs to be a very strong preparedness and strengthening and revamping and revitalizing the different public health initiatives to ensure that such an outbreak does not happen. The challenge here is that outbreaks from different pathogens continue to emerge. Specific challenges come from novel pathogens and those where the diagnostic skills and the diagnostic tools do not exist very clearly at the beginning, and the methodology of transmission and characteristics of that specific pathogen need to go under specific intense study and scientific unwrapping, if you will. This is a slide again that shows that the digital tools can be implemented in the different phases of the outbreak, whether it's during the detection phase, the monitoring phase, intervention, or preparation. The next slide shows a paper, shows a figure from a paper by Geyser et al. In the Lancet, published in the Lancet in June of this year. And I found that it was a very interesting paper by trying to establish a network, if you will, or a platform that can identify the relevant categorical variables that could feed into the digital tool data. It also shows the different functions where digital tools can be used. And on the very right-hand side, you can see here examples of the different countries applying specific tools. This specific platform, I found it also useful, where we will be adding, where any institution or organization can use it to try to identify what would be a useful tool for their specific country or outbreak, what are the tools that exist, and also for the future to add any new tools that actually do exist. If you look on the left-hand side, this actually gives you an idea of what are the major areas where digital epidemiology can be utilized in, for example, specific tools identifying outbreak response. The proximity contact tracing tools is extremely interesting and intriguing, which I will elaborate on a little bit later. Symptom tracking tool, the quarantine tool, or what we would call digital fencing or electronic fencing. Flow modeling tools trying to look into the mobility of populations. Tracking airlines, I found it very interesting at one point during COVID, trying to look at airlines flying over the different countries, and you can see which countries have really implemented early on restriction of mobility and limiting travel. So this was a paper that came out recently, and I think it adds a lot to the dissection of the, or if you want, the anatomy of the digital epidemiology tools. Where would you obtain consent? What are the sources of each one of these different tools that can be utilized? And so on and so forth. The next slide, please, will show us from the same paper by Geyser et al. Yes, thank you. By Geyser et al., you can look at another figure from that specific paper that identifies the 5 steps of trying to put in place for a specific government, for example, or member state. How would you utilize the digital tools? What are the specific principles for the digital tools? And I think that you can actually, it's an interesting figure where you can go from the right to the left to understand the different stages, going through from preparation to planning to specifically the risk assessment, development, and evaluation, to the specific issues that this is actually addressing. I hope that the slides are clear to you, but in the center you can see the issues that need to be addressed can go from consent, obtaining consent, public benefit, repurposing, scientific validity, and these are based on the principles of respecting autonomy, promoting health beneficence, promoting justice, protecting privacy, and supporting solidarity. When we actually— I need your consent on a few items to continue. Sorry for that, big speech. So for example, if we look at the tools for protecting privacy, the importance of transparency becomes very important. The issues of transparency in establishing guiding principles from the very beginning. They were supposed to show, okay. And then actually that was supplemented also with a paper that was published by the WHO, which were the interim guidance and ethical considerations for digital proximity tracking. For those of you who are not familiar with digital proximity tracking, it's an application that tries to identify a suspected case and how close did the device for that specific person come into contact with other devices that are registered in the system, to enable the public health authority to identify the risk of certain people being at risk of being exposed. Now, within this specific interim guidance published by the WHO and accessible on its website, there are the 17, the next slide will show, the 17 different principles on which this is based on. And as an example, it talks about the importance of these specific, in order to sustain ethical considerations, there are specific principles that these digital tools need to be based on. For example, the timeline for how long can these tools be utilized, and that the fact that they should be ended by the end of the outbreak or by the end of the usage or the need for it. There needs to be, for example, an accountability and an independent oversight process for this. There needs to be a very clear firewall between the government body that is using this data and other government bodies that might need to use this data or want to use this data for other reasons, specifically also not just the other governmental bodies, but the private sector, businesses, and so on and so forth. The engagement of civil society also becomes a very important area, and it's important to prevent exploitation of vulnerable populations and ensuring that the engagement of civil society and them backing up certain digital tool utilizations will actually help establish this specific aim and goal. Again, the transparency and identifying to the user the method of the utilization of this data and offering them the ability to opt in or out of certain variables that might be entering into the program. I'll move to the next slide, please. The next slide actually shows, again, we talked about the beauty, and I think His Excellency Dr. Algnawi really emphasized on the eagerness for all of us to be able to capitalize on such data. However, this paper I found interesting because its disclaimer that the challenges are not really mentioned enough when it comes to the utilization of such data, and that's why I wanted to highlight this specific paper by Klingworth and Schnell from Germany, where we need to understand in using digital tools and platforms the availability of internet and the availability of the devices on which this data is being extrapolated needs to be available to a certain percentage, at least, of the community under study. And that representation is still not known. And I think there's a gap, a research gap that needs to be filled to try to understand what is the minimum percentage of a specific community using this digital platform, enable us to provide valuable and worthwhile data that will serve the purpose. In this study from Germany, they also talk about the different steps of how much of the population is using or has access, how many of them are willing to download, knowledgeable about the applications, have no problem with privacy issues, are willing to participate, have the ability to use it. Again, we talk about the issue of age, access, socioeconomic status, and the ability of using internet access. And again, the ability of having the device attached to them at all times and providing the accurate demographics. And again, the paper goes into some more details about describing the challenges when a lot of this information is not available. So I think in summary and in my last slide, I would like to close by saying that this area is of extreme interest, and I think it will allow for the public health community to utilize more data and more information that will enable them to have better detection of potentially economically and health threatening outbreaks and pandemics. Yet there needs to be very clear assessment and prioritization of the research gaps that exist in order for us to utilize this platform in the best way possible. I'd like to go to my last slide, please. And with that, we can see that this really says in a very simple way that traditional and digital epidemiology can be complementary to one another. And I thank you very much again for inviting me for this presentation. Have a wonderful day. Thank you.
Thank you, Dr. Balhi. I now have the pleasure to invite our next speaker, Mr. Rahed Al-Azami, Executive Director, Information Services and Informatics Division at Ministry of National Guard Health Affairs of Saudi. Mr. Rahed, please take the floor. Thank you.
Thank you, Bernard, for the introduction. The year is 1854. The place is Soho district of London Greater Metropolitan Area in the United Kingdom. A cholera outbreak has been raging at that time, and many have been speculating. Is it a miasma-based infection, or it's basically a germ-based infection? But there is one person, one epidemiologist, his name is John Snow, wanted to use methods, techniques, science, maybe technology, we could call it technology at that time, primal, but technology nevertheless. And he took all of the cases and he plotted them on a map, what we call now spatial data. And he found a pattern that most of the cases, they are concentrated on a spot in Soho. And in that spot, at the middle of the spot, there is a street water pump. At that time, people were getting their water from the street water pumps. So he had a hypothesis based on this finding that it's a germ-based waterborne infection. But he wanted to prove the hypothesis, so he shut down the water pump and the outbreak was gone. I just wanted to start with this story just to highlight that modern epidemiology, in its inception, it was intertwined with technology. What we see from the map of John Snow from 1854 resembles what we use now when it comes to GIS. Many actually think that it is the precursor of GIS. Of course, we have come along the way since 1854, and we have invented a lot of technologies, and some of them are emerging technologies, and Gartner has done a beautiful job laying all of those emerging technologies in their publication that they released last month, all of the emerging technologies of 2020. What's interesting is two of the top priority technologies, emerging technologies, transformational and high priority, and in the short term, within 2 years from now, they are related to epidemiology surveillance. we're talking about health passports and social distancing, which we're going to talk about in a little bit of detail later. One of the papers that was published also recently by Ting and his colleagues, looking into the underlying emerging technologies of these two at least, and other epidemiology emerging technologies, and ranking them. So they found that the top are 4 emerging basic technologies. So Internet of Things, IoT, and big data. These are the 2 top. Of course, you want to gather as much as possible data from the field, from cameras, from sensors, from wearable devices. And you do this using IoT. And you're going to get a lot of data out of this. And all types of data, structured, unstructured, and semi-structured data. And where do you store this? You can't store this in a conventional platform or conventional database. You got to have a big data solution. And then what are you going to do with the data? You have to harness the data. So use artificial intelligence. So it comes second. And in some cases, if you have data that has multiple custodians, such as insurance data, some pharmaceutical data where you have the insurance company, you have the pharmaceutical company and the healthcare provider, they all share the ledger, sort of say. You might want to use a blockchain. But all of those technologies, they are the means. They are the vehicle that take you to the goal. They're not the goal. ICT, information and communication technology, they're never the goal. They're the means to take you to your objectives. And in this case, we're talking about epidemiology surveillance. So if we look into the surveillance and its types based on the WHO categorization, so you have national active, which basically is the action of you pursuing and trying to solicit the information and the cases. And there is passive, where you receive the information in a passive way, all kind of epidemiology information, and then you crunch the data and analyze it on the background. And there is Sentinel, where you specify multiple entities to capture the high quality data, and then you rely on the data for further decisions. So out of these 3 goals of surveillance, we have a variety of technologies under our disposal. One of them, which is currently the most mature relatively as an emerging technology, is the social distancing technology. I mean, it's a national active kind of technology. It enables the encouragement for individuals to maintain safe distances, whether it's 6 feet or 2 meters, depends on the unit that is used. And it could also be used for contact tracing, which we're going to see later. When it comes to contact tracing, one of the recent papers was published by Fariti and her colleagues a couple of months ago, actually. They did actually highlight how it could be done and how it could be done with an instant contact kind of model. So at the top left here, if we have person A lives with person B in a home, and then person A want to go to work, this person is riding the train and gets in contact with 2 people, goes to work, gets in contact with 3 people, and maybe nearby, not really closer than 6 feet or 2 meters, and then goes back home. Next day, person A is symptomatic and tested COVID-19 positive. If you have an instant contact tracing solution, it has to be the whole environment. It has to cover all of the entities that are involved. So if you have this instant contact tracing solution, the solution automatically is going to notify all of the people that person A was in contact with to self-isolate and maybe order COVID-19 tests for them. Also the people that were just nearby, that were not closer than 6 feet or 2 meters, maybe notify them, maybe order even COVID-19 tests for them. What they have done in the study, the researchers here, is also they created a simulation model based on mathematical algorithms to compare between having an instant contact tracing versus 1-day latency versus 2-day and 3-day latencies. And we see at the bottom a heat map graph. From the far right, you would see that the success of isolation and quarantining is obviously having a significant rate. And if we go left, step by step, you see the success disappearing all the way until 3 days, which is almost non-existent. So it was very interesting kind of finding that they come up with based on this simulation modeling. There are single-use kind of solutions that workplaces could use, hospitals, factories, et cetera, et cetera. There are social distancing and contact tracing solutions that use commonly used platforms such as smartwatches and other platforms. They have advantages over the single use. You could get better kind of communication and messaging out of them and also capture more information. There are solutions that don't require wearable devices. One of them was developed by Amazon. They have implemented this in a couple of their warehouses. And it just uses a camera with a depth sensor, and it actually monitors the workspace based on the field of view. And we could see on the right side, 3 of their employees, they're not closer than 6 feet. And once they have, one of them came closer than 6 feet, the circle would become red for the person that came closer. The other people will get an orange circle, and then you get an alarm. The solution has been open sourced by Amazon, so you could implement it free of charge. You could have access to the source code, and you could also add contact tracing capability on top of it. There are thermal cameras that also could control access to places and do passive surveillance as well. And there is also the health passport, which is an emerging technology in its embryonic stage. It is a national active, no doubt about this, and it controls access to public and private places based on information that it gets from travel, from health records of the people, et cetera, et cetera. Then it assigns either a health index for the person or maybe the status of the person health-wise. It has been implemented in a couple of places so far that I came and I read about, and one of the largest one is in China. They did implement a solution, they called it Health Code, launched it a few months ago in all of the 23 provinces of China. And the system controls the access to many workplaces, public and private places. It flags each and every person, whether green, yellow, red. And if you are red or yellow, you just can't access the place. On the right side, we see few people lining up, scanning the QR barcode on the table, and then getting the status. So if some of them is red, one of them is red or yellow, they're not getting in, and the data is logged that they were there, other people were among them, and they might quarantine as well. There is India's experience, which is way less scope kind of implementation. Is just limited to rail and air travel. To alleviate the privacy concern, they have open source the solution. So you know what they're doing with the data and what kind of data they're capturing, et cetera, et cetera. But there are also issues other than privacy, which is the proliferation of smartphones. Obviously, based on at least one study, there is no more than 35% of the cell phones in India that are smart. Others are just conventional phones. So what if you don't have a smartphone and you want to ride a train or you want to fly? Are you going to be prevented? It's a big question. Another very promising technology is it's basically based on big data. It's data lakes where you capture all kind of data with all types of data, and then you crunch the data and predict pandemics and also identify the status of the maybe ongoing pandemic situation. Could be implemented at a global, national, or local level. There are a couple of programs I have to highlight, actually. They have the germ of the idea of data lakes, but they don't have the technology itself. So one of them was implemented way in the 1990s, and it was basically a collaboration between Canada's Public Health Agency and the WHO. Although it was implemented a long time ago, it's still within the Canada kind of territory implementation. There is also the ProMed Mail, where they have teams in 23 countries. They capture information and then the information gets published. And there are also aggregators. They aggregate data from ProMed Mail and other sources, even news sources, and then indicate epidemic issues. There is another technology that is on the horizon, but again, it's in a very early stage of development. It's the digital twin of the person, DTOM. And this technology is all about creating a complete digital replica of each and every person in the population. Information that covers almost everything from demographics, health, genetic, financial. Again, it's a very early stage. It will take at least 5 to 10 years based on some of the experts' opinions, and it has a large privacy concern, no doubt about this. Again, according to the hype cycle of Gartner, it's in an early stage, and it could actually allow entities to make real-time decisions, simulate in a safe way, because you're really working on a digital kind of component of the population, which replicates the real population. So something to keep eye on. There is small data versus big data. The problem with pandemics is basically when they are first emerging, they're not providing a lot of data. And with AI, artificial intelligence, they require a lot of data. So what are you going to do now? You're going to wait until you accumulate a lot of data. It's going to be too late. So small data is going to take care of this. But again, it's an early stage, something to keep eye on. All of those technologies have common challenges. There's cost challenge, it's cost to develop, cost to implement, and cost to maintain. There is IT infrastructure at a global and national and local level. You need high connectivity, high coverage, and high-speed connectivity, reliable connectivity as well. And you need back-end resources to support implementing all of those technologies. And there is privacy issues, probably on all of the technologies that we covered. A privacy issue that exists now, maybe in the future, or maybe not actually. So one of the studies by the University of Southern California, recent study, has shown that the concern about data privacy across generations. Let's look at the bottom row here. They're very concerned about data privacy. Baby boomers, and that was limited to the US. So baby boomers, they were, almost half of them were concerned, 47% of them were concerned, very concerned about data privacy. But look at Gen Z, the generation that share everything on social media. They're 28% concerned. So are we gonna see less and less concern about data privacy along the way? So maybe the technologies that we talked about, the emerging technologies that have big privacy concerns will be just viable, maybe. But now we're living in the current time and we have to deal with privacy. So implement as much as possible layers of privacy protection, data security that would add more layers, non-discrimination, a layer to protect certain minorities, and also transparency. So Dr. Balkhi mentioned transparency as a key player to get the buy-in from the public. So people have to know what kind of data you're capturing, what are you doing with the data, et cetera, et cetera. And also in some applications, maybe you don't need to capture identities. Maybe you just capture findings from the edge site. At a global level, we really have to have a strategy for digital epidemiology surveillance, a strategy and roadmap, similar to what Gartner has done with the emerging technologies matrix on the right side, something that tackles short-term, mid-term, and long-term, and all kind of priority levels. Also, we need to tackle the digital maturity at the global, national, and healthcare systems across the globe, data interoperability, integration, data sharing. Maybe some of the programs that we just covered, ProMed Mail and other programs, their issue not detecting, and we saw the survey that we just had. A lot of people, almost 50% of the people that responded, they did not believe that predictions of COVID-19 were successful, as far as I understood. So probably having a data sharing would make programs that are already implemented more successful. And also, if we implement programs that are based on emerging technologies, we're going to get better success. Investment in emerging technologies that we talked about and more for early warning systems and also accurate predictions, real-time predictions. We have to really change our ways of doing things. The virus mutates itself all the time and changes its tactics. Ourselves as humans, we have to do the same things, obviously. Thank you so much for listening. I hope that you found this speech informative. Thank you so much.
Thank you, Dr. Riyadh, for this very insightful presentation. I now want to welcome the co-chair for this session, Chiara Poletto, a researcher from Institut Pierre-Louis Epidemiologie et de Santé Publique in France. Chiara, please join us to go through the next part of this session, which is discussion.
Thank you so much, Dr. Mariano. So good morning, good afternoon, good evening to everybody. So thank you so much. I'm happy to be here, and I would like to thank you, the speaker, for this insightful session. It was really great to see all these things together. A very nice perspective of this challenging topic.
Thank you, Chiara. Let's go for the questions to the panelists that came from the audience. So I'll take the first question addressed to Dr. Bahi. The question is it expected to have another peak for COVID-19? And there's a second question to that is why there is no unified global system for epidemiology to facilitate access to information, address infectious disease, and take actions easily. So it's basically, it's two questions. One, do we have another peak? And why there's no global system for epidemiology? Dr. Balhi, the question
Thank you, Bernardo, and thank you very much. Can you hear me? Yes?
Yes.
Okay, thank you very much. Welcome, Chiara, again to the platform. Thank you very much for the audience, the person who asked this very critical question. We've been asked that over and over again. A second peak, I think we need to, this is the first time we've been facing such a situation over the past 100 years. And I think a pandemic that's lasting and continues to evolve over the next months that we see, each country will be looking at their own epidemic curve, and a second or third or fourth peak, whether hopefully not as high as any country's first peak, is probably something we're going to see in many countries. I hope not all countries. And the reason behind that is the platform for developing a vaccine for the coronaviruses does not exist the way it does for influenza. So in 2009, when we saw the H1N1, it was very imminent that the vaccine was going to be available. The impact that this virus has on economy pushes us and forces us that we need to figure out ways to open up our systems, our education, our trade, our economies, to be able to survive and to save lives and livelihoods. And while doing that, we will see smaller outbreaks in the different countries. However, I think it's critically important that we be patient with this pandemic and that we understand that we are all on an extremely steep learning curve with this specific virus. I'm happy to answer any variations from that question, but that's the short answer to it. with regards to why is there not a, or will there be a specific platform to share data and for us to be able to manage this in a more, in a faster way, in a more efficient way. I think I want to refer the audience back to the international health regulations, which was a mandate agreed upon by the 194 member state countries. And where I was part of a review committee for Ebola 2014, it was very clear that many countries have a bit of a conflicting interests, because in one perspective, we want to secure our borders. We want to ensure that we are not exposed to emerging pathogens. But at the same time, countries find it difficult to announce and be super transparent with what is evolving and what is happening in a public health perspective on the ground. And I think one way for us to be able to create such a platform that is accurate, efficient, and provides accurate data is for us to understand that the public health issues around emerging pathogens are not unique to any one specific country or to any specific culture or behavior. And if we are not honest to be able to study and understand what are the reasons for this happening, we won't be transparent enough to address these situations. So again, I think we need national unity, we need global solidarity, and we need to be able to adopt the international health regulations, which actually allows for better data sharing and intervention implementation around the world, for us to be able to manage this as truly one community. Over to you, Bernardo. Thank you.
Thank you, Dr. Balkhi. Chiara, you might want to maybe make some observation or perhaps even take some of the questions from the audience. The floor is yours.
Yeah, I saw a couple of questions that are quite interesting. And so for Dr. Alzame, did you think about the data validity that you got from the people? That's quite a specific question. But it's always about data, maybe on a completely different level for Dr. Balkhi, how WHO verify the data that are gathered? So how verify that the number of infected cases collected worldwide are accurate? So I think these are like two faces of the same coin.
Yeah, that's a very important question. And it has been going on in the data science realm for years now. It's not even specific to digital epidemiology, but it's highly relevant to digital epidemiology, especially nowadays. When we are calling for data sharing between regions, countries across the globe. There's no way to standardize data. There's no way to control the quality of data from the beginning. So you have to deal with the quality of data after the fact, after you receive the data and you put it in a reservoir, maybe a data lake. In the data science realm, when it comes to data quality, there were two schools of thought in the beginning. So one school of thought, and that was the first one, was about starting with a high quality data, then analyzing it and make informed decisions based on the high quality data. So do not do anything, do not analyze, do not start acting until you get top quality data, and then you start. This turned out to be highly challenging, even within the same organization. It became next to impossible because what they call a phenomenon known in the big data realm, which is the data explosion that has been happening over the last 20 years, where the generation of data has been increasing significantly. So the other school of thought said, you know what, let's not do this. There's no way to start with high quality data. So you start with whatever data you have, you start analyzing it, and then you will identify the issues, eliminate the issues, and then go back and analyze. Then eliminate the issue, go through this cycle until you end up with a data that is workable. And that's the theory of data lake.
Thank you, Dr. Raed. On the question about the WHO, how to verify data regarding number of infected cases worldwide, whether it's accurate or not, as you know, WHO has member states, and the member states are providing all the data to WHO, and there's a whole network that started from the time of influenza to collect data from the countries to then create the global picture of a pandemic. So that network exists since the period of the influenza, and it's being used currently. And so basically, the data that WHO produce on the current pandemic is the data that country deliver to WHO. If the question is whether, the question says whether how reliable it is as reliable as member states, countries provide to WHO. So that's so we work in an ecosystem of trust where we trust the member states that are providing the data that is reliable because it's for public global good, public health and global health, and therefore the teams that work with the member states, our emergency teams do work with member states to provide that current data. But you might have seen that also there are other data sources from universities that do complement data from member states. And actually, sometimes there is a difference between Johns Hopkins data, for instance, and WHO data. Johns Hopkins has also its own network of data collectors from member state that collects from each country, look at all the social media, and then they collect data. So the data from WHO is verified by the member states and is our official statistics and data from a member state. And if there is any issue, we normally contact the member state to discuss, to see the correction or address any issue that comes with the data that is provided. Dr. Balkhi, you might want to complement Dr. Raed's comments on the data side.
Right. Again, just to re-emphasize the issue of the data sharing from the member states to WHO, going through the regional offices. So the WHO has 6 regional offices, and it has over 100 or almost 180 country offices. And each country is mandated or has, one way or another, the international health regulation focal point. That focal point is responsible for reporting to the WHO through the proper channels on through specific guidance and guidelines. Some of the pathogens need to be reported within 24 hours, some within a week, and some on a regular basis. So the IHR focal points are the ones who need to verify, and they're nationals, so they belong or they report to their governments. They're not WHO staff. And I think when we talk about the issues that my colleagues have just mentioned, it is the willingness to share this data, but it's also what we need to emphasize in this specific summit is there needs to be a huge emphasis on strengthening public health infrastructure. Because if we continue to talk about data, we need to understand that data needs to come from a specific source. So if we do not have the trained people, if the countries and the member states are not investing in enhancing public health infrastructure, surveillance program, public health specialists, we will never be able to get the quality of data. And digital data, as most of us would probably agree, is complementary to a public health system that needs to be strong, viable, and supported. So I'll stop here, Bernardo. Thank you.
Thank you, Dr. Balkhi. There is a follow-up question for Dr. Balkhi. It reads, I just want to ask, in your own perspective, how ready are we, the world and healthcare, in regarding the adaptation of effective digital epidemiology? And then that's for you, Dr. And then Chiara will ask perhaps the last 2 questions to Dr. Riyadh. So Balkhi, you
Okay,
have
thank you very much. Thank you very much. So again, I think maybe I preempted my answer already, but I think how prepared is the world to adopt digital tools? That's the question, Bernardo, correct?
Yeah, yeah.
Yes. So I think what is the COVID pandemic, in my humble opinion, has pushed us towards a more expedited need and desire to adapt specific tools. Again, I think in understanding that the global impact of COVID surpassed multiple times the economic crisis that happened in 2008, 2009. And I think it's the economical impact of this outbreak that has really pushed us to try to enhance and support members and government, member states, and governments themselves, again, need to adjust their public health infrastructure, empower it, and be able to really look into the challenges that have already been published in the literature about the challenges for applying digital health and for it to survive. So initiating it is one thing, but allowing for digital health tools to survive and progress within a specific country, they really need to ensure that they're adopting the ethical and legal considerations that will allow for this specific technology to thrive and survive over the next years. When we talk about the legal issues and the ethical, the propriety, the autonomy, the transparency, the accuracy of these data, and the personal autonomy and privacy, these are things that may be major obstacles in the progress. So I think there's a lot of hope that digital epidemiology will be able to fill in the gaps of traditional epidemiology, but without addressing the legal and ethical issues, without creating a strong public health platform, they will not be able to prosper. Over to you, Bernardo.
Thank you. Thank you, Dr. Balkhi. Chiara?
Yeah, so I would like to ask two questions to Dr. Reed. The first one is, are there any evidence correlate the pandemic with the geographic location? So that's the first question. The second one is, how can we use social health code in tracing, improvement and treatment of diseases in Arabia social community?
Well, it's based on some of the simulation modeling. I mean, again, it's an early stage to get some results of studies about contact tracing because we're still in the middle of the pandemic where this technology has been established and it will take some time until researchers start aggregating data about the outcomes of the contact tracing and then identify the best method of how do you do it, and secondly, how effective each and every method based on the situation that we are dealing with. But as per the Ferretti study that they have conducted that I presented, which was based on a simulation model. Again, simulation modeling is not highly accurate, but it could actually help a lot when it comes to knowing about the outcomes of certain kind of actions. So you really want to do it in a safe way by doing it in a digital kind of environment. Then you apply it on the ground. What was the second question, Kayara? Or the first question?
So, the first one, are there any evidence correlate the pandemic with the geographic location, that correlate maybe the pandemic with the geographic location?
Well, I mean, the geographical information system has been around for some time now. Surprisingly, again, many think and believe that the precursor and the prequel of what we have now has been developed and initiated by an epidemiologist. And it has come a long way now. Nowadays, there are technologies of GIS, Geographical Information Systems, that allow you to plug AI into GIS analysis. So not only you are visualizing the data that you have, and then you would need to interpret the data and try to find some sort of patterns and issues. AI could be put on top of the GIS and identify issues for you in a semi-automatic way, or maybe automatic way at some point in the future. So GIS has been evolving a lot, and the realm of epidemiology is one of the fields that GIS could help a lot, actually, predicting issues, and also during situations, assist in making informed decisions.
Thank you, Dr. Riyadh. Thank you, Dr. Balkhi, co-chair Chiara Poletto. We are now ending this session. I want to thank all of you, that participants, and then I think the question now is, how can we use the leadership of Saudi Arabia with the G20 presidency to take this very important issue to the next level? Chiara, you might want to just put some comments around that before we close and wrap up the session.
Yeah, thank you so much. And yes, so it was really interesting to see these two talks, because they put one after the other important facts about the acceleration, the huge acceleration of digital health, digital epidemiology, and digital surveillance, and about the fact that in this context, actually this pandemic occurred. So this is even more prompting actually in quite an abrupt way an acceleration. I think that clearly the world won't be the same after, and also the way approaching pandemics, preparedness and reaction to pandemics won't be the same. So thank you so much to the speaker, to the chair, Dr. Mariano, and to all the public that addressed this interesting question for this very interesting discussion.
Thank you very much. And once again, Kingdom of Saudi Arabia, thank you for taking digital health and digital epidemiology to the stage, and then also look forward to work together with all the panelists, but all the stakeholders to drive this transformation, to bring better health outcomes to everyone, including those ones that are not necessarily connected to internet, which is part of almost half of the world that needs still connection to the internet. So let's not forget those ones too. So thank you, everyone. Thank you very much, and it's been a pleasure to have heard from the panelists, but also from having heard the questions from the participants. And I hope this was very interesting for all. But this is not the end, this is the beginning. So let's make this beginning a beginning that will last long and deliver those very positive health outcomes to all of us as we fight the pandemic, including the COVID-19 pandemic. Thank you. And thank you, Chiara.
Thank you so much. Thank you.
In the digital era. Now we will share with the audience 2 polling questions for our next session, Pandemics Predictions Model. The first question, on a scale from 1 to 5, how strongly do you agree with the ability of prediction models in anticipating the pandemic's next move? 1, strongly disagree. 2, disagree. 3, neutral. 4, agree. 5, strongly agree. You have 30 seconds to answer. So as we can see the results, basically the majority do agree with the ability of prediction models in anticipating the pandemic's next move. So for the second question now, on a scale from 1 to 5, how strongly do you agree with the value of real-time data such as social media, Google searches, and mobility data in improving existing prediction models among other registered health data records? 1, strongly disagree. 2, disagree. 3, neutral. 4, agree. And 5, strongly agree. We will have the results appearing in a bit. So as we can see, the majority do agree with the value of real-time data in improving existing prediction models among the other registered health data records. That's interesting. So now we will be diving into the topic of pandemics prediction models. To do so, it's my pleasure to introduce Dean of Medical Faculty and Chief Executive Officer of Johns Hopkins Medicine, Dr. Paul Rothman. Welcome, Doctor.
Thank you, William. My name is Paul Rothman. I'm the Dean and CEO here at Johns Hopkins in Baltimore, and I'm so happy to be part of this event today and talking about a topic that's really important. As someone who runs a large health system, the ability to predict the pandemic is so important for ensuring that we're able to provide the best care for our patients, both those with COVID and those without COVID. In addition, it's important for us to be able to keep the people who take care of these patients, our staff and physicians, safe. And so this is a very important topic, and I'm proud to be part of the session today. Our first speaker is Dr. Eric Voles, who's a senior lecturer at the School of Medicine at the Imperial College in London. Dr. Voles is a mathematical epidemiologist who has spent more than a decade modeling a variety of disease outbreaks. He specializes in outbreak analysis, pathogen evolution, and a contact network epidemiology. Recently, like many of us, he turned his attention to COVID-19. Today, he's going to discuss use of predictive modeling to understand the pandemic, particularly lessons learned from modeling of the early stages of the disease. He's also going to discuss more recent findings of a mutation, the D614G mutation, that may affect the future course of the pandemic. Dr. Voles?
Thank you, Paul, for the wonderful introduction. And thank you to the organizers for inviting me to speak on this topic. It's been fascinating to assemble the materials to review this. So can we predict pandemics? And this is a very simple question with not a very simple answer, I'm afraid. It depends what we're trying to predict, and it depends over what period of time we're trying to predict. So next slide, please. Some things are more predictable than other things. So things like behavior, political reactions, and later on I'll show evolution tend to be highly unpredictable. Actually, you need to go back one slide, I'm sorry. Thank you, that's perfect. I will argue two main points. So one is that the global pandemic was actually highly predictable by around mid-February. And so I'm saying this partly with the benefit of hindsight, because if we could go back in time and poll scientists in mid-February, I think we would still find a very high diversity of opinion. But I will show how the key pieces of information were available then to say that a pandemic would be highly likely. A corollary to this is that the pandemic is much more unpredictable now. And that's because we're over the first wave, and the future course of the pandemic depends on things that we can't predict very well. It depends on evolution, it depends on political considerations, it depends on behavioral fatigue, which is a slightly controversial term. It depends on vaccines, and we do not yet know if we will have an effective vaccine. We don't know how quickly production of an effective vaccine can be scaled up. We don't know if we'll have a vaccine which is therapeutic or actually sterilizing and preventing transmission. So all of these are really giant unknowns, and we won't really have greater clarity about these things until autumn and winter of this year. I'd also like to begin with this thought from Soren Kierkegaard. Life can only be understood backwards, but it must be lived forwards. So this was Kierkegaard anticipating predictive modeling hundreds of years ago. And it is the case that when we're looking into the future and trying to extrapolate some epidemiological quantity into the future, the methods that tend to work best are those based on epidemiological principles, models and methods that are fitted to pre-existing data and explain that data well. And so I'll show you a few examples. Also, I have to say that I'll largely be reviewing the work of my many talented colleagues at the Imperial MRC Center for Global Infectious Disease Analysis. I can't claim credit for much of the wonderful work I'll show you, as well as Community Jameel GID Center for Global Health Analytics. And I'll conclude with some talk about evolution of the virus, and that draws heavily on the UK COVID-19 Genomics Consortium. Next slide, please. So I think everyone viewing will have seen figures like these. These show short-term projections only looking 1 week in advance for the number of COVID deaths in a variety of European countries. This is based on a regularly updated model from the Imperial MRC Center, and you can find dozens more predictions like this on our website. So this sort of predictive modeling has gained a new level of prominence. We see figures like this in mass media and newspapers, and global health organs like the U.S. Centers for Disease Control also now published aggregated forecasts. These sorts of short-term forecasts are a modest but highly visible success of predictive modeling. But of course, they tend to not work very well very long in the future, which is why, well, typically from reputable sources, you'll only see such projections made 1 or 2 weeks in advance. And that's also reflected in the width of the confidence intervals in these plots. The pink region tends to expand very rapidly as you go into the future. And these sort of short-term predictions are also based on very simple data sources and very simple models. So we've talked quite a lot about the importance of alternative data sources and mobility data and electronic contact tracing data. But actually, the majority of short-term forecasts are based on traditional epidemiological sources, in this case, reported COVID-19 deaths. And indeed, deaths have been the main time series data used for short-term forecasting for many months now. The reason is that it's easier to standardize across countries. So if you do want to generate forecasts for many different locations, it serves as a very relatively uniform statistic, although it's not without problems of its own. For example, if we want to translate COVID-19 deaths into some estimate of the unobserved prevalence of infection in the country, we need some estimate of the infection fatality rate. And that certainly does differ over time and between places. So for example, countries with younger populations would tend to have lower fatality rates. And in well-resourced countries, and mostly in the developed world, the quality of care has improved quite a lot over the past couple of months. And so we've actually seen infection fatality rates trending downwards, largely thanks to antivirals like remdesivir and therapeutics like dexamethasone. Although it's not the subject of this talk, I would like to note before moving on that mathematical models can serve a useful purpose looking months into the future, going into autumn and winter of this year. But they serve a somewhat different purpose in that case. They're mostly used for best and worst case planning. So the figures on the right show some work by Patrick Walker at the Imperial MRC Center. They've also developed a tool that can look at scenarios months into the future for dozens of different countries. And these data are based on South Africa. And so this shows exactly how much we must suppress transmission in order to keep incidence below rates that would overstretch health systems. And so again, this doesn't serve as a very accurate projection. We can revisit this 6 months from now, and I think it'll turn out to be quite different. But it does help policymakers to hope for the best and plan for the worst, as the adage goes. Next slide, please. So epidemic prediction and mathematical modeling serve different purposes at different stages of the epidemic. Very early on, when we have a new infectious disease, we want to know, does it have pandemic potential? Will it spread to multiple countries in the world? And if it does, what will be the cost to human health? After a pandemic is underway, we want to know more about global dissemination patterns. So which countries are most likely to be heavily impacted and which countries need to be on guard. And then finally, when the pandemic is properly underway in multiple countries, then we move on to the short-term forecasting, such as we saw in the previous slide. And the purpose of that is to track our progress towards control and elimination, hopefully. So I believe the first scientific report pointing towards pandemic potential of SARS-CoV-2, the virus which causes COVID-19, is due to Natsuka Imai and Neil Ferguson and colleagues at the Imperial MRC Center. January 20, and shortly thereafter, they published a series of reports directed at the WHO, but also made public, which suggested that there were many more infections in Wuhan than were reported in official statistics. And this was based on an alternative data source. This was based on previously measured airline passenger flows from Wuhan to other international destinations, and a very small number at the time of writing this report, it was only 7, observed infections among expatriated travelers from Wuhan. So even though there were only seven cases among these travelers, taking into account things like the number of passengers on these planes, the population size of Wuhan, and the number of people likely to have traveled through Wuhan, they were able to say that the likely number of infections as of January 20 was in the thousands, or a central estimate of around 4,000, which was actually quite big relative to the number of official reported cases. So I read this report and I became involved in the MRC Center response shortly thereafter. My role in late January and February was to bring in genomic epidemiology methods, using genomics as another alternative data source, especially for estimating when the pandemic began, so when there was a cross-species transmission event into humans, and also estimating growth rates. And so I published that work as the MRC Center report number 5. And this indicated that the epidemic was doubling in January and February about every 5 to 7 days. It was also importantly consistent with the idea that there was only a single cross-species transmission event. That actually reduced pandemic potential because we'd be in a very different situation in terms of control if there was a large animal reservoir and many ongoing transmissions into humans. And certainly coronaviruses have given us some recent examples of that happening. So for example, the Middle East respiratory syndrome is a related beta coronavirus, and that does have a large animal reservoir with many transmissions to humans. So this was the limits of our understanding around early February. We knew a pandemic was possible. We didn't know if it was likely. We knew that there were many infections, and we knew that it was growing quickly. Next slide, please. So that alone isn't sufficient to say that a pandemic will definitely happen. Another important piece of this puzzle is how many transmissions are likely initiating epidemics in other countries. So shortly after I published the phylogenetics report, Sangeeta Bhatia at the Imperial MRC Center published report number 6. And this was provided some of the first estimates of the likely number of infected individuals traveling to other countries who would not have been detected by passenger screening. So we can think of each individual counted in this report as being someone who could go on to trigger a new epidemic. This report was really only based, again, on a fairly small number of reported infections in early February found in other countries, but we could compare countries where we thought that screening was very effective or very sensitive, or where they were likely capturing a majority of cases, and so we used Singapore as such a case. And then we could compare that to the expected number of infected people traveling to other countries. And so that the figure on the left shows the expected number of infected individuals visiting many different countries. Each point represents a different country, versus on the x-axis, the observed number of detected cases. Anything above the diagonal of this line represents an undetected case. And there are more than 10 countries in this report where we found that there were probably more than 10 undetected cases. So that certainly suggests that a pandemic could happen, and this is the sort of activity I was engaged in mid-February. You can do some very simple back of the envelope mathematics to work out the probability that an epidemic would happen in each of these countries as a function of the number of imported cases. And I think this is not something I will publish or ever will publish, but it's a very good example of the sort of ad hoc reasoning that I think many experts were using at the time when they were trying to estimate when a pandemic would happen. So this is not a particularly original theory. This goes back to epidemiological methods developed in the 19th century. So this is not hot, cutting-edge methods at all. But basically what it boils down to is if we know the reproduction number, we can and we assume that transmission rates are equal between individuals, then we can estimate the probability that an epidemic will not happen following a single import. And then we can compute the probability that an epidemic will happen as 1 minus the probability of no epidemic raised to the power of n imports, if we think there are n imports. Okay, and so the figure at the bottom right shows the output of this calculation, actually something slightly more complicated, accounting for heterogeneous transmission rates. And so we can see if there are 10 imported infections, then there's actually a more than 90% probability of an uncontrolled exponential growth of a new epidemic in this country. So we have about a dozen countries with more than 10 imports, each with a very high probability of an epidemic. At this point, this was about the 3rd week of February, I personally made the judgment that a pandemic was very likely. Next slide, please. So this was not a consensus position at all, because there was still some hope that contact tracing, very effective sequestration of cases, and case management could prevent large epidemics in other countries. And so I think the people in late February, or the experts in late February who thought that there would not be a global pandemic, were clinging to this idea that very effective contact tracing would save the day. After the 2003 SARS epidemic, Christoph Fraser, who then worked at the Imperial MRC Center, did a theoretical study comparing, while evaluating qualitatively the pandemic potential of different infectious diseases as a function of both reproduction number and the proportion of cases that occur from asymptomatic individuals. And this was a very prescient study. So, for example, he could anticipate that the SARS 2003 was controllable despite having a very similar reproduction number as we have in the current COVID-19 epidemic, because relatively few transmissions happened from asymptomatic individuals, and contact tracing was consequently more efficient. But we also have at the opposite end of the spectrum something like HIV, where a large number of transmissions happen during chronic asymptomatic infection with a similar R naught, and of course we cannot control HIV very easily. The COVID-19 epidemic is somewhere in between. So there's still quite a lot of debate about how many transmissions happen pre-symptomatically or asymptomatically, but it's certainly much greater than in SARS 2003. This anticipated the difficulty of actually effective contact tracing to prevent epidemics in many places. So work by Joel Hellawell and colleagues at the London School of Hygiene Tropical Medicine formalized this argument. They did a very detailed simulation study of contact tracing in the bottom right, where they accounted for realistic incubation periods, realistic time to detecting cases, different proportions of asymptomatic and pre-symptomatic transmission. And they also reached the conclusion that control is not very likely after there has been several weeks of cryptic transmission in a country. So this further anticipated the situation we're in currently. Next slide, please. So going ahead from February to March, we do actually have a pandemic. WHO declares a pandemic in early March. What then is the likely pattern of international dissemination? So which countries should be on guard? So we saw fairly early epidemics in Iran and Italy, northern Italy, and in Washington State in North America. But what other countries are likely to be hardest hit, and what other countries may the epidemic be growing, but simply hasn't been detected yet? So some very nice work by Matteo Chinazzi and Alessandro Vespignani at Northeastern did a very complicated simulation study using an alternative data source, the International Air Transportation Database, which measures passenger flows between more than 200 locations. Combined with a fairly detailed epidemiological model for how an epidemic would spread in different locations. And they used this to estimate the likely proportion of transmissions from Wuhan and from other locations in China, both before and after the cordon sanitaire that was implemented in Wuhan in late January. And so a very nice thing about formalizing these arguments within a simulation model like this is we can examine counterfactuals. For example, what would have happened if the cordon sanitaire was not implemented in Wuhan? And so they found that the travel restrictions implemented in China did not actually substantially delay spread to the rest of China, only by about 3 to 5 days. It came a bit too late to have a substantial impact on the rest of China. However, travel restrictions from China and enhanced passenger screening did substantially limit the number of exportations. They estimated about 80% limited transmissions from China to other locations around the world. The predictions of this simulation study is something that we examined a bit later using genetic data. A very nice feature of genetic data is for retrospective modeling, estimating when an epidemic likely began in different places. And indeed, we saw a kind of ladder of transmission from East Asia, for example, locations in China, followed by Korea, Taiwan, Japan, Thailand, Australia, followed by many locations in Europe and North America almost simultaneously, and then going on from March to April, more outlying areas like Brazil. Next slide, please. So now in March and April, we get back to the short-term forecasting that I mentioned earlier. And I would highlight one especially nice example of this by Seth Flaxman and Samir Bhatt at the Imperial MRC Center. Again, the staple data for this sort of analysis is the time series of COVID-19 deaths. But a nice aspect of their modeling framework is that it could easily incorporate alternative data sources. And in this case, they were able to make great use of aggregated cell phone mobility metrics. So Google, Facebook, and others have been publishing average transportation or average human mobility in different venues and different settings, like public transport, work, home, and so on. And this can be inputted as a time series within the framework developed by Seth Flaxman and Samir Bhatt. When they include this mobility data, they actually are able to gain much greater precision in their forecasts. And this was especially the case in March and April. It also serves as somewhat of a warning for overinterpretation of alternative data sources, however, because going into May, the quality of forecasts using these data has actually decreased. And the reason for that is human mobility is actually correlated with lots of other things. It's correlated with a lot of other interventions that are partially effective, like mask wearing, hand hygiene, social distancing, and so on, that aren't captured in those time series. And going from April to May, we've seen human mobility ticking up in most places, especially North America and Europe, but reproduction number hasn't crept up. It has crept up, but not quite to the extent that we would expect based just on mobility data. So using such data sources does require a lot of care. Another alternative data source is genetic, and this is what I primarily worked on in the spring. The tree on the right represents a phylogeny of SARS-CoV-2 sequences from Mecca and Saudi Arabia. These were data provided as part of a collaboration with Arnab Hain at the King Abdullah University of Science and Technology. And we can use these genetic data as an alternative way to estimate how quickly the epidemic is growing, as well as when the epidemic likely originated. So the central panel, the gray ribbon, shows both the estimated number of infections through time, and everything to the right of the dashed line represents a prediction of this model, so an out-of-sample prediction. And in this case, we see that the estimates match the reported cases quite well, and we were able to detect that the reproduction number was decreasing by mid-April. Next slide, please. So I'll conclude with this bit of recent work from my group from over the past summer, which I think very well illustrates the limits of predictive modeling. So something that we have a very poor ability to predict is evolution of the virus, and the virus is a moving target. It's important to remember that this virus has only been circulating in humans for about 9 months. It's only passed through dozens of generations, and we should expect it to adapt in various ways to its new human host. So what we've been able to determine recently is that a mutation that arose in January and February likely increased the transmission rate of the virus. And this may well go some way to explaining the different epidemic course that we've seen in different places. So this mutation, which is called spike 614 D2G, was noticed in April because it was increasing in frequency relative to other genetic variants at the time. And it was postulated that this might have some impact on transmission rates. A number of laboratory experiments were done subsequently using pseudotyped engineered viruses, which showed that indeed this D2G variant had enhanced rates of infecting cells under laboratory conditions. But we cannot say from those lab experiments what the likely impact would be on transmission rates among humans. So this is something that we've only been able to estimate recently using a very large data set from the UK Sequencing Consortium. This comprises more than 25,000 whole genomes from the UK. And what we've been able to observe from these data is that both the rate of growth and the rate of importations of the G variant, the more transmissible variant, increases over time. And we can also look at different sub-epidemics based on phylogenetic methods resulting from different introductions of genetic variants into the United Kingdom. And we see that sub-epidemics descended from introductions of the G variant tend to be about 50% larger than epidemics from the ancestral variant. So although we have a very wide confidence interval, we now do think that this genetic variant increased transmission rate, perhaps around 20%, but a wide confidence interval from 6 to 56%. So what does this mean in terms of prediction? Well, in in mid-March, when this G variant became the dominant form in the United Kingdom, or became the majority form, the UK was under intense debate about when to impose a national lockdown. And with the benefit of hindsight, the lockdown probably came a little bit too late. One of the reasons that we were a bit surprised, or the lockdown came a bit too late, is that the epidemic we now know is doubling faster than we expected. In February, based on the experience in Eastern Asia, we might have expected an R0 around 2.5, and what we ended up with was an R0 above 3 in many European countries and in the United Kingdom. And so certainly if you increase R0 of 2.5 by 30% or so, you do get something that's more consistent with what we observed in the UK. And this mutation, it certainly deserves further study, but this may go some of the way to explain why the epidemic was growing faster than we thought it would, and why we were caught by surprise. So next slide, please. So finally, I need to thank again my many talented collaborators at JIDEA and the MRC Center and the UK Sequencing Consortium and the organizers for inviting me to speak on this topic. Predictive modeling is not a new research area. So I think mathematical epidemiology is a field which has existed for many decades, in fact. But it's a field which has received a lot of new attention with the COVID-19 epidemic, and certainly an area deserving more attention, I think. Among published COVID-19 research that we've found on Google Scholar, only about 2% of papers indicate that they provide some kind of quantitative predictions. So certainly an area requiring further development. Thank you.
Eric, thank you for a great talk, and I want to thank you for all the work you and your colleagues have done at Imperial College during the pandemic. Next, I'd like to introduce Dr. Ali Muqdad, who's the Chief Strategy Officer for Population Health and a Professor of Health Metrics at the University of Washington. Over his career, Dr. Muqdad has published groundbreaking work on local level disease trends and key risk factors for poor health. His work on obesity is among the most highly cited in the field. As Director of Middle Eastern Initiatives at the University of Washington Institute for Health Metrics and Evaluation, Ali is developing new research projects and collaborations with regional leaders in population health. Today, he's going to talk about his work modeling the spread of COVID-19 in the Middle East. Dr. Muqdad.
Thank you, and good morning from Seattle. Thank you for the introduction, and it's a pleasure to be with you, and thank you for organizing this important meeting. So I want to talk about IHME projections, COVID-19 projections. The history of our model started by our university hospitals asking us to help them with their surge capacity, how many beds they need, how many ICUs, how many ventilators. And that's how we started doing this for our own hospitals, other hospitals, our county, and then eventually every state and every country in the world right now. An IHME model provides expected daily deaths in the future, of course, total deaths, but also provide an estimate for hospital needs and resources in terms of beds, ICU, and ventilators. We use mobility data from Google, as the previous speaker mentioned, Google and Facebook, and premise here in the United States. We also incorporate in our model testing, and we project as well confirmed cases and estimated infections as we go into the future, part of our projections. And we are in the third version of our model. We have realized that with this virus, as more data comes in, we need to change our modeling, the strategy, in order to capture the new data and do a better projection. So briefly here, the first model was a curve fit, which did very well in the United States, projecting the peak, but didn't do very well when we started coming down in the United States. So we switched to an SEIR model and curve fit hybrid. And the reason at IHME we didn't start with a SEIR, susceptible, exposed, infected, infectious, and removed, because early on we didn't know for many parts of the world how many people are being infected and how many people are susceptible. because lack of testing early on. And now in the third version of our model, we're doing a random knot combination spline as a hybrid model with SEIR. In our model, we use a lot of variables in our projections. Mask use, we have data on mask use. We have several variables on mask use. When you go out, do you always use it or sometimes use it? We have mobility data, as I mentioned. We see a strong association between COVID and pneumonia seasonality. So we have pneumonia seasonality in our models. We have testing per capita. We have density of the population. We have particulate matter 2.5, smoking, altitude, and pneumonia death rate. And we have, right now, we're exploring adding other variables, including some surveys that you are getting right now. When you are outside your house, how close you come to other people, how much contact you have, and humidity as well. This is our SAR model. Like every other model, I'm not going to spend time on it. One of our variables that we used early on as a key driver of cases and deaths are the mandates. And we looked at 6 mandates that every country had imposed. These mandates range from closing of educational facility all the way to airport closure. So 6 in total. As you can see, every country in the world, very few exceptions, went into these lockdowns sometimes in March. So it all happened within a couple of weeks in March. And that's what has helped countries who had less seeding of the virus early on than countries, places when they locked down, like England, as the previous speaker mentioned, and here, for example, in New York. When they locked down in New York, it was too late in a way. When Florida locked down, it was very good for Florida because there was not much seeding of the virus going on. I'm not able to advance my slides correctly, so I'm sorry about that. This is percent of people wearing masks as of August 4, and you could see a huge variation. And what's important here to notice is very high in Saudi Arabia, United Arab Emirates, and Qatar and Oman. It's very high in the Southern Hemisphere, where the COVID-19 right now, due to seasonality, is having more of an impact. In South America, for example. Less so in parts of the United States and in Canada, where we don't see high mask using. Next slide, please. This is percent reduction in mobility. We've seen reduction in mobility early on, especially with school closure of school and education facilities in the United States and in many countries. Unfortunately, started April, we started seeing a rise of mobility, and right now in many places we're almost back to normal. And you could see here in the United States, the states that are most hit with COVID-19, which was on the news, Florida, Texas, Arizona, and California, you see mobility will decline automatically as there is an increase in cases. People start being afraid and they start putting up the defense mechanism, and by reducing their mobility, wearing their mask and staying away from each other when they go out. Next slide, please. This is testing per 100,000 population, and you see a huge variation in the world. Parts of Africa, not so much been going on in Pakistan, Afghanistan, as you can see. In South America, not that much as well. And a huge variation in the United States when it comes to testing, variation between the states. Next slide, please. And for each of our location, and for many countries, we can do it at the subnational level. This will be our effective R, which is changing with time for the United States, and this will be the percent infected in each state, where we estimate not only the reported infection, but what's the percentage of infection 4 months into the future until December 1st. Next slide, please. And we validate our estimates of infection compared to the studies that are being done on antibodies, with exception of a couple of studies in Spain. We're doing very well in estimating the percentage of infected cases in every location. Next slide, please. We also compare our models to everybody else's model and how we perform 4 weeks into the future. We do very well 4 weeks. as we project into 4 months into the future, like every other model, our confidence interval is much wider, as the previous speaker mentioned. Next, and we release those publicly. Next slide, please. So here are some of our results for the United States. We're expecting by December 1st, we'll have 295,000 deaths. And we're providing two scenarios. The red one here will be if we keep relaxing our social distancing mandate, will be about 391,000 deaths, 295 if we enforce mandates when mortality reaches 8 deaths per million per day per state. And then the green one, if 95% of people wear masks in the United States, and we do it for every location in the world. And the idea here, 95% comes from what we see the highest, which is Singapore. They have 95%. And the 8 per million is the 90th percentile when countries and locations put a lockdown. 90% did it at 8 per million. So we're being a little bit conservative here. Some countries did it much earlier. But the results here show a huge difference. If people wear masks, we can delay a lockdown in the United States, and we can save 66,000 lives between now and December 1st if 95% of the US population wear a mask. Next slide, please. This is Saudi Arabia, for example. We are projecting 5,800 deaths in Saudi Arabia until December 1st. We don't see a need for a lockdown in Saudi Arabia, so they will not reach the 8 per million per day deaths, but 1,000 deaths less to be achieved if 95% of people in Saudi Arabia wear the mask. Right now in Saudi Arabia, mask wearing is around 75%. Next slide, please. For Saudi Arabia, we are showing here how much beds they need and how many ICU and ventilators. The red one on top, all beds available. So Saudi Arabia will not have a shortage of beds, will not even have a shortage of ICU or ventilators because they have a strong medical system. Next slide, please. This is the Iran. We're expecting in Iran where Iran had a larger epidemic for several reasons. Iran in January had a sporting event where athletes from China came to, in January, and from Wuhan, they came to Iran. So that's how it started and spread through religious places in Iran to other places in the region. Iran, 71,000 deaths. We would expect they will go into a lockdown sometimes in October. And next slide, please. In Iran also, we expect that they will have a shortage of bed sometimes in November, in the peak of the second wave. I don't call it second wave, it's still the first wave. Second wave is we go to zero and we start over again. This wave is staying with us. It's going up and down as a roller coaster. It goes up, it comes down, it goes up again. So Iran, the second wave that will hit them will run out of beds. They will not have enough beds. They will not have enough ICUs compared to what I showed you in Saudi Arabia. Next slide, please. One of the limitations for our modeling is excess mortality. Right now, we're modeling deaths, reported deaths by every country in the world, and we are aware from many locations where we have data on a weekly basis by cause of deaths. We know there is excess mortality due to COVID-19. We also don't know what's the percentage of people who are infected because there are no random sample surveys of antibodies for in many countries right now that done in a systematic, regular way that we allow us, all of us, to know what's happening in every country, how many people are infected, how many people have been infected and have antibodies right now. And then we have seen right now that in many places, our expectation for ICU, because there is an improvement in our ability to treat the patient, now we have less admission, less need for ICU, less need for ventilators than we started modeling early on. So we're changing as new data coming to us. And of course, whenever you see a peak of cases, what's making it hard for us in our modeling is people change their behavior and government impose mandates or dial back some of the relaxation what they have been put in place earlier on, like our state here where I live, state of Washington, started relaxing certain mandates. When we've seen a peak and several outbreaks, we dialed back some of our relaxation measures. Next slide, please. What we are needing right now, and we recommend that we need to know more about hospitalization, because when the testing is happening right now and you know how many people are positive, we don't know, are these people who sick and showed up or symptoms, or these are people from a random sample that's done on a regular basis to monitor COVID-19 in a population. So we're using hospitalization as a proxy. So we say how many people are hospitalized out of the tests that are positive. And then we know then what is the percentage of people who are tested with symptoms and as a proxy out of the total population. So hospitalization, we don't have it for every state in the US. We don't have it for every country. That has been a challenge. Getting a better handle of excess mortality so we don't estimate the impact of this pandemic. Doing more antibody surveys every month so we know what's happening, how many people are infected, and we can refine our models. Transmission early on is taking different form because of people who locked down, especially in, like the previous speaker mentioned, for a while. In April, we didn't see any cases. What happened here in many countries in the world, including in Iran, when they locked down and the cases came down and opened prematurely, the people who came out and about were very careful, wearing their mask and staying away from each other. They didn't see COVID-19 for a while. They assumed victory and they assumed there is no more COVID-19 circulating. They let down their guard and started coming up again. So we have seen this roller coaster. It goes up, it comes down. We have seen it in many states here. When people start reacting, it's behavior, it's not the virus. It's behavioral change and what the countries are doing and what the people are doing that is impacting our way. And we're noticing right now, like when we have a mandate, we have 8% increase in a short time from a mandate, what we have seen in Texas, and we have a 15% increase compared to 18 when we have a mandate and enforcement of that mandate. So it's behavior of the people themselves that's changing the trajectory of the pandemic and the behavior of the government, what they do in order to stop the rapid increase of the virus. Next slide, please. So right now, what we're doing at IHME, we're providing 3 scenarios: business as usual, mask 95%, and a lockdown when we reach 8 per million, you lock down for 6 months. That's part of our model. It's available on our web for every country. So now people are coming to us and a lot of authorities are asking us, help us with balancing the economy and opening up for business, saving lives and saving our economy. So saving livelihood and both. What we're trying to do now, we're modeling what we call a pulse, where you can lock down for 2 weeks, open for 4, lock 2, open 2, lock 2, open 6. And then these scenarios will be available from IHME. We have them right now. They're going through quality checks, and we will release them soon on our web as well. The other thing that we have been asked to model right now is what if we close certain businesses and what will happen? So closing the bars in the United States, for example, keeping schools closed, keeping restaurants closed, what will be the impact on the COVID-19? Will a universal mask mandate and closing of certain businesses allow us to keep our businesses open until we have a vaccine available or an effective drug? And then now we're looking at how could we model the phased vaccination approach. We've been asked to set a priority for vaccination based on what the National Academy of Science is doing right now in the United States. And we've been asked to model that to show if we start rolling out these vaccines when they are available, what will happen when we vaccinate the first wave and so on. Next slide, please. Thank you very much for inviting me, and thank you for the government of Saudi Arabia to arrange for this conference. Thank you.
Thank you, Ali, for a great talk, and thank you for the role IHME have been playing in predicting the pandemic. We're now going to spend about 15 minutes answering questions from the talks that Ali and Eric gave. We'd love to get questions from the audience. Please send them in now so we can answer as many as possible. But before we begin, I'd like to introduce my co-chair, Dr. Sasu Talkoma. Dr. Talkoma is a professor and head of the Department of Computer Science at the University of Helsinki in Finland. Over his career, he's published over 240 scientific publications and has 10 US patents. In recent months, he and his colleagues have been working on investigating contact networks and mobility patterns, as well as smartphone and cellular network data to better understand and predict stages of the pandemic. He and his colleagues recently published a commentary in The Lancet focusing on the future prospect of data fusion and multi-scaling modeling, as well as the need for new technologies that can improve data privacy. Sasu, what do you think about what you heard this morning so far?
So I think the presentations have been really great. So this is a very important topic, and it's really great to participate in the event. And thank you for the introduction. Also a warm welcome from my side as well for this session.
Great. So we're getting questions via WhatsApp. I'm going to take prerogative and ask the first question for both our speakers. You both mentioned seasonality in your new predictive models. Can you talk a little bit about the impact you're seeing of seasonality, and if that impact is due to biology of the virus or changes in human behavior?
I can say a little bit about what we've done on that. And please interrupt me if you want to chime in. So we have looked for a correlation between growth rates and climate variables, so things like humidity and temperature from month to month, and we've seen virtually nothing. Other groups have also looked at this at different scales, both globally, and I think we have a lot of excellent data from China now. So, you know, within the epidemic in China, which had tens of thousands of cases, we have a very big range of environments in terms of temperature and humidity. And so this also didn't find any correlation between these variables and growth rates. I think seasonality might become a much more important variable going into autumn, and that's for, again, behavioral reasons. So I mean, what we have is a new virus. It's a very competent virus. It can be transmitted very easily. It doesn't apparently matter very much if you're in a hot, humid environment or a dry, cold environment, which we know can matter with other viruses. But what will definitely matter is density of human contact. And so we know that tends to increase with opening of schools and in winter months when people spend more time indoors.
So we have looked at the temperature and in our data, the relation between temperature and infections. And early on, it was a very weak association between temperature. For each 1 Celsius increase, there was less than 2% decline in transmission. It was holding early on in the United States, but and everywhere in the world. But when you start adding what's really going against seasonality, so it was supposed to come down in the United States because the weather was getting warmer. But increase in mobility happened at the same time. People stopped wearing their masks and started, you know, we opened our bars, and we've seen what happens here in Memorial Day. So that overwhelmed the effect of temperature. But in our models right now, when we show seasonality from pneumonia, it's a very strong association with infection rate that we find in our model. So it's in our data. We keep seasonality for pneumonia in our model as one of the covariate in our projection. And there is a strong association between pneumonia. And pneumonia, if you in the United States, for example, it never goes to zero, where like the flu comes down very low and starts picking up in the fall. Pneumonia doesn't go down all the way to zero. So that's what we're noticing right now. Adjusting for mobility, mask wearing, distancing, and all the other variables still is a strong effect.
Sasu, you want to ask a question?
Yes, so I have one question for both speakers. So it's about the impact of AI techniques for predictive modeling. So as we know, the AI field is evolving very fast, and we have, for example, deep learning methods that can help in finding new insights from the data. So how do you see the role of AI solutions in the predictive modeling of pandemics? So Dr. Volz and Dr. Mogdad, please.
I think AI definitely has a role to play, but the fact is it hasn't played a very prominent role in most of the modeling efforts, at least in the first few months. And I mean, I think that's both a function of the difficulty of the problem and dealing with many different types of data which need to be prepared and cleaned in various ways before they become useful, and also a consequence of the fact that we already have fairly good statistical models that have been developed over decades, and again, when we're mostly dealing with traditional epidemiology data sources like new infections and deaths, there's not a great deal of new insight you can bring in with machine learning or AI methods, unless you have some other new additional data source. So I mean, I wouldn't say it's played a very prominent role in predictions so far, but again, now going forward over the first wave, the situation is much more complex, and we've had more time to prepare. So I think it may have a bigger role going forward.
We don't use AI in our modeling here, and what we spend a lot of time on is really prepping and cleaning the data and making sense of the data before we put it in our models. And I don't see a big role for AI at this stage for this model. You need a lot of data set to inform AI in order to do better prediction, and this is a new virus.
Great. First question from the audience. Is the pandemic affecting the rate of other communicable diseases? I think Ali mentioned a little bit about it. Do we see any changes in other communicable diseases?
Yes. So unfortunately, we have, even with the lockdown and the virus, we're having a lot of impact on other diseases, non-communicable and communicable diseases. And that's more of a concern in low-income country and low-middle-income countries where there is a delay of HIV treatment, immunization, and so on. And of course, the economy and the lockdown for many countries in the world, where they make their earning for that day, working that day, they don't have reserve. Malnutrition, if you take a country like Egypt or Pakistan in the region where they were facing a stunting problem or malnutrition or overnutrition, that will be even more of a problem. What we're seeing also, last point, and I'll let the other speaker add, what we're seeing right now, some reports from South America where we see less flu. So there are some positive impact on some other infectious diseases where people, because of their behavior and their staying indoor, wearing a mask, washing their hands, there is less of a flu in South America. And our concern in the United States was like the second phase that's coming ahead will coincide with all the respiratory diseases of fall and winter. We don't see it as big right now in many parts in South America and Argentina and Chile, because people are staying away from each other, and that way we see less flu circulating at that time. Over.
Yeah, I agree with all of that as well, and I'd also add a point about the impact on infectious diseases that spread in a similar way by droplet aerosol as SARS-CoV-2. So we've seen a big impact on influenza across the board. I'd also throw in Australia as another place where the flu epidemic is basically not taken off during its traditional season. But there have also been some other impacts I've seen on diseases that have a very different transmission route. So especially in March and April during the lockdown, there was a lot of excitement among the HIV prevention community because they saw this as an opportunity to actually prevent many transmissions because they think that many transmissions happen during the first few months of infection. And if you can essentially prevent people from coming into close contact for several months, that should be able to interrupt a lot of HIV transmission chains as well.
Great. The next question from the audience is, what is your view on herd immunity? How many people will have to be infected to get it? And do you account for that at all in your models?
So we do account for how many people are infected. So in a way, in our model, because we estimate that, and it's a covariant that goes in our projection. So let me talk about, you see me smiling, there is nothing to smile about when it comes to COVID-19. Herd immunity, in my opinion, it's something we use in epidemiology for a vaccine, not for an infection. And for me, when we start talking about herd immunity in our community, it's basically we admit failure and let the virus circulate among ourselves. And I don't think any of us is saying that. Herd immunity will be very costly. If you take the surveys that we have right now in the United States and elsewhere, so take New York City, for example, antibodies survey showed 21% antibodies positive. Look how many people died in New York City in order to reach that level. So to go to 40, 60, 70, or 80, how many people are going to die from that? So what we're seeing right now, there is a lot of theories about a lower effect of a lower level of herd immunity. But let me explain that. And I'm sorry for taking so much time because this is something very important. We're seeing a herd immunity. People are saying there is a herd immunity at a level of 20 and 30% infection in certain locations. Let me explain why the danger of that. In parts of Asia right now, because there are other infections from coronaviruses, there is some T-cell recognition and there is more defense of the virus because attacking the COVID-19 as a recognition from previous exposure to coronaviruses. But when it comes to a low herd immunity in some countries, like now in Pakistan, COVID-19 comes into a geographic location and starts spreading in a country. Started in Wuhan, spread all the way in China. When you're looking at Wuhan when it happened, or in Beirut when it entered Beirut, there is a circle of individuals, some of them unfortunately due to harvesting effect will die, and some of the key spreader, like the guy who's in the pharmacy or in the store, gets infected. So even at a lower infection rate, the circulation drops down a little bit in that locality. Then it's spread to another circle and it goes all over again. So it's a full sense of security when people tell you right now that we see herd immunity at 20 and 30%. My response to that is wait a little bit. You've seen it in that location because of people who died and people who are infected, what we call a super spreader. But once it moves outside that circle, it's going to spread all over again. We've seen it in every part of the world. We've seen it in Iran when they picked up in April. It came down for a long time. Nothing happened. And the Iranians felt, oh, we don't have a problem. We've seen it in Florida. So herd immunity is very concerning for me when people talk about it. Over.
Eric, do you have any thought on it?
Yeah, I would echo your concerns about generating a false sense of security by arguing for lower levels of herd immunity. This is actually a somewhat controversial topic. I mean, not just in the political sphere, but among mathematical epidemiologists as well. There are well-reasoned models developed by good scientists that have suggested that herd immunity levels could be lower than would be suggested in a lot of traditional models that have very homogeneous rates of transmission and homogeneous susceptibility. And that may well be the case to some extent. But the problem with this is that it's not something that we can predict very well. It's not something that we can measure until well after the fact. So it's not something that we should assume will work in our favor in the future. Again, I mean, I completely agree with the previous comments that we should assume that a very large proportion of infection is required for herd immunity and not count on 20 or 30% being adequate.
Great. Another question from the audience. With a forecasting done on a national level in a large country such as India, China, or Indonesia result in skewed data since the transmission of virus in the different cities might be dynamic depending on resources and population density?
Very true. We do projections and we haven't released it in India at the state level, in Indonesia at the province level. We're doing in the United States, as I showed you, at the state level, and now we're moving to do it at the county level. And yes, there is a total difference for several reasons. One of it is behavior change due to the infection rate, but in the United States, I'll give you the example, that holds true in Indonesia and in India. In the United States, we have a state and we have a county within the state. Some counties have a mandate for masks and there are people wearing much higher rate of mask. If you do the whole state, you're averaging. If you take Florida, Miami had always a mandate for mask, had a lockdown before the rest of the state. So you get a false picture of the whole state unless you go down to a smaller locality. We do projections at the local level in Brazil. If you look at our data in Mexico, wherever we have that data, we do it at a smaller level at the state level. But a very good point, and you're right.
Eric, anything to add?
Briefly, one of the reasons, again, that death time series have been the most widely used, and it's most easily comparable between countries and over time. So we have huge changes over time in testing rates, also big differences in sensitivity of tests, and it becomes so much the harder if we're actually trying to compare regions with very different testing behaviors. Yeah, I mean, one strength of alternative data sources like genetic data in particular is that it's actually very robust to biased sampling. So, if we have a good random sample of genetic data from a location, it's largely immune to these problems of different testing rates or different testing rates through time.
Can I say something about testing, which is very important? Early on in the US and in many places, testing was strongly associated with a reduction in cases because you were able to remove these cases, isolate them, and we were able to do contact tracing, testing the contacts, isolate them, identify them first. Right now, with the testing in the United States, that has increased rapidly, and in many places in the world, even some parts of the Gulf, that exceeds the capacity of the public health system to do tracing. And because you increase your testing in many places in the US and others, there is a delay in giving the results, sometimes in the US 3 to 4 days, which makes tracing obsolete. I mean, you can't do it, and your public health system is overwhelmed. You take a state like Florida, again, 15,000 cases a day at one point of time, 12,000 before, 10 before. There is no way a public health system could do the tracing. So right now in our data, as testing is increasing, we're seeing a less impact of testing on the projections and the declining of infections. So there is a comfort zone where a government or a locality can do testing, do it right, and do the tracing. Above and beyond that is for treatment purposes, not for a public health and controlling the pandemic, unfortunately. Over.
Great. So here's an important question. Based on your data, how long will the pandemic last?
We're not really on a path to eradication.
We are doing a projections all the way right now to the end of 2021. We haven't released it, but we've been asked to do it, and we have presented it to some authorities here in the US and elsewhere. It's going to be with us for a long time until we have an effective vaccine or an effective drug that will change everything we are doing. Sorry, over.
Great.
I would also say that we're probably not going to be able to eradicate this virus, even if there is an effective vaccine. And we certainly can't eradicate influenza despite having at least a decent, partially effective vaccine. And certainly this is on the same order of difficulty as seasonal influenza. So I think we should probably, the baseline scenario is we have something like what happened in 1918, where we have a virus that continually adapts and we see changing its form and generating new variants going forward.
And the concern we have is many people right now are saying they will not take the vaccine. It's something that we need to spend time on and do a lot of education right now about the importance of this vaccine.
So Eric and Ali, I'd like to thank you for your time today, informing our audience about both the models and getting your advice. It was great and really appreciate it. So I'll let you wrap up and give me your thoughts on what we heard this morning today.
Thank you. So and thank you to the speakers. So really excellent presentations. And I believe today, so we heard about how the toolkit for predictive modeling is evolving. And I think it's evolving fast based on what we heard. So there are good techniques that have been extensively used in predicting the different stages of the COVID-19 pandemic. And then we have these newer directions, for example, longer term predictions and using these different data sources, for example, smartphone data and so on, to support the analysis. So, so this toolkit is really it's evolving, and I think that's a good thing for our communities and helps to then support evidence-based decisions for detecting and mitigating pandemics. So, so these developments contribute to the world health security, and I think these are my thoughts from this session today, and really excellent discussion.
Oh, I agree. I would also take away that both speakers talked about how robust the models are in the short term and how the confidence of the predictions long term is not as great because of the variables that they discuss, such as different government policies, changes in physical distancing, masking that go along with changes in the prevalence. And this idea that we're going to rheostat our social distancing over time, and that will affect the spread of the virus, I think was what we heard from both speakers, and I agree with that. So, again, Sasu, thanks for being with me today. We appreciate it. And again, thank the speakers in the audience for participating today. We really appreciate it.
Thank you.
Thank you all for such an insightful session on global case studies of pandemic predictions. So now we'll share with the audience 2 polling questions before our third session titled Communication of Public Health Crisis COVID-19. The first question, in your view, what are the main aspects of building robust communication surveillance? 1, data accuracy. 2, public acceptance. 3, technology maturity. 4, technology cost. 5, global, national, and local data sharing. You have 30 seconds to answer. We will have the results appearing in a bit. So the majority chose global, national, and local data sharing as the main aspect of building robust communication surveillance. So now to the second question. On a scale from 1 to 5, 1 being the lowest, 5 being the highest, how strongly do you rate the effectiveness of global communication surveillance during COVID-19? We are about to display the results in a bit. So the numbers are close, between 3, 4, 5, as the audience strongly do rate the effectiveness of global communication surveillance during COVID-19. And now, we will be diving into the topic of communication of public health crisis COVID-19 in this session. And it's my pleasure to introduce the Johns Hopkins Bloomberg School of Public Health, second century distinguished Professor Dean Emeritus, Professor Michael Cluck. Welcome, Professor.
Thank you so much. It's wonderful to be here with everyone today. Good morning, good afternoon, and good evening. It's great to be here with everyone today. I've very much enjoyed the sessions, and I think the session that we put together for you now will be equally good. Communication is critical, as we just heard from the last speakers, in changing behavior during a infectious disease epidemic and pandemic. Today, we're very fortunate to have with us as the speaker, Dr. Hani Joktar, who is the Deputy Minister for Public Health in the Ministry of Health in the Kingdom of Saudi Arabia. Dr. Hani is trained in medicine and infectious diseases, and he holds advanced degrees, master's and public health degrees from the University of Manchester in public health and infectious disease control. He's held a number of leadership positions in Saudi Arabia and has been a member of the committee that's helped to organize today's sessions. So without further ado, I'd like to welcome Dr. Hani to the screen.
Hello, everybody. Good morning, good afternoon, and good evening for everybody. I'm very glad to be speaking to you today about what has happened in Saudi Arabia and our experience in COVID-19 in terms of technology, utilization, data communication, and how we used our existing digital technology, looking forward to have a better public health technology in the future. Next slide, please. Today, I will take you through the beginning of the story in Saudi Arabia. Actually, we were luckier than many other countries because we started our cases a little bit late, which gave us a small opportunity to develop our system, watching and observing what's happening in the rest of the world. Early on in January and February, we saw countries with good and decent healthcare system were hit by a number of cases that exceeding their capacity to handle public health strategy and public health defense mechanism. As a matter of fact, we discovered actually that the public health technology is not up to the level that countries can handle such a big pandemic. Most of the technology in the past were directed toward hospital case setting or public or primary healthcare setting. The public health digital services was not as we faced right now. So what we said to ourselves when we saw what's happening in countries with good or actually better in the best top 10 countries in the world with healthcare system, we saw how they were their healthcare workers were not capable to cope with the public health services and approach. Public health practitioners were struggling and get exhausted in the beginning of the disease. When we looked at ourselves, we said, okay, let's sit back, let's set up our team, let's look at our technology. We have many technologies on the ground. We need to look at it. We see what we can benefit from what we have on the ground. And let's kick off. We have our command and control center. We have the emergency operating center. They are there. They are functioning for a few years right now. Let's make them readier and let them ask for what they want in order to make our technology team ready to help us in this pandemic if it happens at all in Saudi Arabia. Then we looked at our dashboard room, actually, which is our National Health Command Center. And that center actually has launched its function officially about a year ago. And it was getting in the preparation for the past 2 years. That command center actually looks into the hospital operations and primary healthcare operations. And we said to ourselves, can we utilize that? Can we transform that into something else? Yes, let's look at it and let's review how can we get benefit from that. So that is our dashboard. The third element on the slide is the education and awareness. We know, or we knew that time, that this is a new disease, a new virus hitting all countries. I'm still in the first class, in the first slide, previous slide. Hitting all countries, people getting information from everywhere. We have good information and bad information. So we thought of, why don't we develop our communication system, making our information appropriate. So we created our portal of all scientific communication available, easily approaching people. Education, we made our education tailored for people. So we used our existing digital system to help us in that. The fourth element is how we add to enhance our digital application. We in Saudi Arabia, as I said, we have, we will show it, I will show you in a few minutes how we used our existing model, and we added to it some new digital technology. And we also partner with the SDAIA to make sure that we have a very collaborative digital system that helps in pandemic control. The last part is the camera and security. From my background as an infectious disease prevention and control consultant, when we look at infection control practice, usually in such a disease, respiratory disease, most of the transmission happens in the crowded and high mobilization area, like the emergency room. So we thought that we need to make sure that we have a very good view on the emergency room by implementing and making cameras available in all mobility units inside the emergency room, preserving the patient's right and confidentiality, making sure that we can, even with these cameras, we can define the people who are in contact if in case a case has happened, and trace them back, go back to them, catching them up, making sure that we test them and make them under our radar. So that is basically the presentation is about. I will focus on some of these areas to show how we in Saudi Arabia handled such a program of merging the old school public health with the new digital area or new digital era that we are looking forward to have in public health. Next slide, please. This is the room that we are watching our public health. Actually, all of our functions in the public health. This room, as I said earlier, it was built for hospital operations and primary healthcare operations and supplies. During this pandemic, we thought, or we think, why don't we make this room readily available to help us in controlling the disease, looking at cases. We can even drill down. I will show you also in one of the slides how we can drill down to a single case to define it. In this room, we have all the dashboards that we can look at our available beds, available isolation rooms, available ICU beds, our ventilator, functionalities of the ventilators, functionality of the emergency room. We can see the cameras in the emergency room that I just talked about from this room. We can also look at contact tracing, easy testing. We can look at the mass testing, you name it. We have it all in this command center. So we converted this National Health Command Center to a command center where we can observe all what's happening on the real ground during this epidemic or during this pandemic. Who can access data from this room? The minister, the vice minister, all the deputy ministers, other healthcare sectors, leadership, all the other governmental entities who might need to help us, so they can look at this room, look at the content of the materials in that room, and they can develop their system to help us moving forward in a better way. In this room also, we have, because it's a clusterized disease, as we heard earlier from Dr. Ali, when we have a cluster, and the super spreader make a network of cases around him. We have an early warning system in this room where we can spot on the growing clustering area, so we can capture it, trace it, make sure that we get all the cases prior it spreads out of that cluster. So that room was kind of a great added value to us. Next slide, please. Our second pillar was the mobile health support. We in Saudi Arabia, we used to have the Maw'id system. Maw'id is an appointment, which is CAS, which is Central Appointment System, where people can reach out to this appointment system. But anybody who has an official residency in Saudi Arabia can just use their ID. They put their data, and they get an appointment in the primary care. We said we can use this central appointment system or Maw'id to screen people, to make it like a triaging point for people. So people, they triage themselves on Maw'id, and then those who have symptoms will be escalated automatically for an appointment. So what we were trying to do in here, we were looking forward to make sure that our symptomatic people are being looked at. Why? Because we want to make sure that at least 80% of symptomatic people get traced, tracked, and diagnosed. So we were trying to improve our symptomatic people approach or delivery of care to them. And we used this first, this was our first tool we used in the epidemic. Together with the 937, 937 is our health call number. It's well known in Saudi Arabia. Anybody call 937, they will have access to all kinds of services. These services, either general services or healthcare question, or even consulting a physician. So we made that available, and I will show you how our number grows up in a bit in the 937, which is again has another arm inside it. Instead of telephone call, we have an app which is called Saha. We also empowered our Saha app, where people can consult a physician either through texting through the Saha app, or through telephone conference through the Saha app, or through video consultation as well. We have also empowered our chatbot, where we created some digital. It's a new thing. We created some digital artificial intelligence in its preliminary phase, where people, they put some of their symptoms, and it takes them to different portal of healthcare access. So this is how we use our existing mobile health support. Next, please. This how we used our, again, this is, these two apps are readily available in Saudi Arabia. They were in the, I don't want to say beta version, but they were on their trial, and we were pushing for them to capture all health care services to people under Sahati, the one on the right-hand side. And all practitioners, they can access their services through an app, the one on the left-hand side. Why we have these two, or why we chose these two? Because they were already existing, and we wanted to capture on them, making sure it deliver public health services as well. This is these two apps are going to be the future app in Saudi Arabia for a provider of care, which is Anat, and the recipient of care, which is Sahati. The Sahati gives everybody, today, it gives everybody the Maw'id, which I spoke about earlier. They can book their appointment through it. It provides them all the healthcare education and awareness. It provides personal health dashboard. It gives you your weight, your exercise, your blood pressure dashboard, your heart rate dashboard, what have you. So it is a very beautiful app. People can book appointment for tests as well. We have the mass testing. We also have on the other side, the ANAT is the physician platform or the practitioner platform. I can prescribe my medication to my patients in here. I can also give a prescription for somebody, a suspect case. I can give him a leave for 2 or 3 days until he get tested, until he get cured again. We can do all of that through ANAT. If we look in the middle, we have Teams. We used also Microsoft Teams to conduct a virtual consultation. And the virtual consultation took a very big role in the Saudi healthcare system during the curfew, where people get stuck. They want to see their doctors. Many of them, they're afraid to go outside. So we gave them the opportunity to use Teams to consult their physician. Next, please. This is how our doctors and our patients see the, on the right-hand side, see the consultation platform on Teams or Sahati as well. As I told you, I will show you some numbers. In Saudi Arabia, in the first half of the year in 2019, we had, on the medical consultation app, we had 1.3 million. And this year, first half of the year, we have 4.3 million. Of course, the growth, bulk of growth because of COVID. On the 937, the phone call, we had in 2019, in the first half of the year, we had 4 million calls, medical calls. And in 2020, we have 13.2 million by the end of June this year. So it's a tremendous growth. People loved to use the technology. So is there an opportunity to have further growing or further development in public health? The answer is yes. We need the tool to be more available. Next, please. Taqassi, which is contact tracing. Remember the slide that I show you, our National Health Command Center room? Unfortunately, the picture is very small. This black circle in the middle is the circle which we love. I'll tell you a story about this. As I said earlier, that many countries in the beginning where we saw them getting exhausted, their public health practitioners get exhausted because everything, public health platform were not ready. We said, let's go and develop something. Taqassi means tracing. So we created this online platform for tracing our cases. So in the beginning, at the very beginning, before this was kicked off, we started on the conventional tracing technique that public health practitioners do, where people go using their small notepad or paper, write some information, and then go back home or to the office, put the data on Excel sheet, send it, and it is a manual kind of public health intervention. We said we cannot live with that, especially if the number grows up. We need to create something. So we focused. We created Taqassi thanks to our team and the Ministry of Health. They created this Taqassi. The black dot in the middle or the black circle in the middle, every dot inside it is a case. If you click on that case, it will show you a bigger picture. Each case indicates either or tells you if this is an index case or if this is a primary, secondary, or tertiary case. And it tells you the contact. It tells you contacts by definition, by ID number. So we can go back to patients or to contact list by ID number, by phone number. So it defines everybody. And we can see that inside that National Health Command Center. 8 information that we can get, or 8 elements inside this Taqassi program. 4 of them, the 4 on top is people can use, all healthcare workers use Taqassi to enter all the patient's data or the client data inside the mass testing program. So before you test everybody, you triage people, you put all the information inside it. The second box, which is active target surveillance. So we use it also in active targeted surveillance when our team goes into an area where we suspect an outbreak or something. As Dr. Ali mentioned earlier, when we have a case and multiple cases around it, we send our team, they do active targeted surveillance for that population. They use Taqassi, so they enter the data in there, and it will all automatically reflect on that black circle. The third one is contact tracing. We do all of our contact tracing through Taqassi. The last one is COVID-19 patient suspect monitoring. Remember when I said earlier that we make people triage themselves in Maw'id? So if I triage myself and I have my my triage says we give a score, if the score is high enough, it will automatically be mobilized to Taqassi, and in Taqassi, somebody will call that patient to bring him over for testing and medical check. So that is the service part. The second part is we use Taqassi for all patients in the quarantine. We use Taqassi to put the data, follow-up data for all patients in the hospital. We also use Taqassi to do the daily data collection from patients under the isolation. And we also register mortalities inside Taqassi. So Taqassi is a hub for us today. It's an online platform. We just created this platform during this pandemic, and looking forward to have Taqassi works for all communicable disease, not only for COVID-19. Next, please. This is the second thing which we developed during this pandemic, which is Tatamman, which is in English, it's rest assured. Tatamman is a platform we first thought of it to do the geofencing for those under isolation. But now we are removing that criteria because Sadaya with Tawakkalna, they have their app, which will be, I will be highlighting it for its here as well. But then, because it's rest assured, we want to make sure that people use it as my caring partner on my phone. So it's a digital caring system where people can access easily through to 937, and 937 actually will call if you upload some symptoms, they will call you directly. All the education material are very accessible, and it is tailored for you. As I said earlier in the beginning, we try to make all the awareness and education tailored because it reads your data, your health data, and your occupation and so forth. So it gives you public health information that is tailored for you. We also do daily monitoring of health status. We do have the symptoms. You put your own symptoms and it tells you how healthy you are. So it is another caring technique. And it also gives you a dashboard, of the disease itself. So it also tells you what's in the news out there. And up to date, we have 1.376 people, 1,376,000 registered in Tatamman. We have more than 900,000 people booked appointment through it, appointment for mass testing. We have also 300,000 help requests, which we reacted for. We have also followed up more than 500 people under isolation, in home isolation, prior to Tawakkalna took that function from us. Or took that function, we want them to take that function actually, because we want this to be caring body. Next, please. The mass testing journey. Actually, from the beginning of the disease, we said, we thought that people will be running out to test themselves. Why don't we create something new? We saw it actually in Korea, in South Korea, and we said it's perfect, fantastic idea. we immediately run places for drive-through and mass testing, and we have a location in 17 cities. We tested more than nearly 1.5 million people in these mass testing drive-through. We have 3 locations in Riyadh, 2 locations in Jeddah, 1 in Mecca, 1 in Medina, 1 in Asir, 1 in Dammam, plenty, so in 17 cities. And the smaller city, we have many drive-through. The big one has 12 drive-through. The smaller one have 6 or 4 drive-through, depends on the size of the city and the size of the population. As I said earlier, appointments booking is very easy through Sahati application. If you remember that, the application which I said, the platform for the people, and through the Tamman application as well, we can book. Lately, we created ability to book also through the primary healthcare. So sometimes people go for primary healthcare, they have some symptoms and they don't recognize that could be for symptoms of COVID, but the doctor has the privilege to book them testing in these centers. This strategy helped us to increase our testing and isolation tremendously. If you remember, I said earlier that our goal is to test 80% at least of those symptomatic with the mass testing, and we have the fever clinic. I'm not talking about it here because it's different venue. The fever clinic, which we created in Saudi Arabia, which is called Tamman Clinic, we delivered access to care to 100% of people who wants to test. Our assumption that 80 to 90% of people with symptoms, they go for testing and they get it. 100% of those who go, they get the testing, and 90% of people with symptoms, they reach out to these centers, either the testing or to Tamman Clinic. Next, please. In the beginning, I said that we have a collaboration, and thankfully, we have Sadaya in Saudi Arabia. They help us tremendously to develop our tracking or tracing apps. And the geofencing, we have it in Tamman, but we don't want to have it because we don't want people to look at it as a tool that we might restrict their movement. We want them to register because it's a caring tool. So Tawakkalna took that role. It's a fantastic app. People can get permission during the curfew time. People, they used to get permission to walk, permission to go do some essential house groceries purchasing, or if they want to go to healthcare services. So these choices were there, and it served people fantastically. The one on the left is Taba'ud. Taba'ud is an app where it sends a notification for those who have been in your contact zone if you are a case. For example, if I'm a case today and I'm registering, once Taqassi capture me, it sends my information to Tawakkalna. So Tawakkalna will restrict me, and the Taba'ud part is optional. It's my option. Do I share with people who have been in contact with me? Of course, all the data is anonymous. Nobody knows who is that person who shared his data with you. But it is optional again. I share my result, so people who were in contact with me during certain period of time, at certain distance, at certain social barrier, they will be notified that you have somebody who has been in contact with you who is positive now. So they give them the option again to test and trace. Next. That's it for my data, but there is something here that we in Saudi Arabia very proudly serve the pilgrims who come to Hajj every year in huge numbers. Over the last 10 years, our number were never dropped below 1.8 million pilgrimage in Hajj. last year we had 2.5 million people. The crowded picture show one prayer time during Hajj last year. And we in Saudi Arabia built our capacity digitally to develop an early warning system where we have a syndromic information and all healthcare provider sites in Mecca and Medina capture this syndromic bundle. And once the patient has these symptoms or syndromic criteria, it pushes up the data to the EOC in Mecca. We see it and we react to it. So in the last 5 years, we haven't had any public health since we developed the EWAS actually in 2016, and ever since it's the surveillance program, and we have never had any public health threatening outbreaks in Hajj. This year, we experienced that actually in 2014. Hajj was during the MERS, Hajj was safe, alhamdulillah, and everything went smoothly. 2009, again, we in Saudi Arabia were capable to handle it. 2009 with the H1N1, we were capable to handle it, and nothing went wrong, and it went smoothly. But this year, because of the flight restriction and the worldwide pandemic alertness was really, really unprecedented. And that is the picture on the right, where we have how did we implement social distancing in pilgrims. We continuously having our early warning system functioning during Hajj this season as well. We used our application for Tatamman, for Taqassi, for all of these pilgrims who have performed Hajj. And I think this is a great lesson to us in the future. How can we control a better and easier Hajj season? And how can we use digitization again in controlling pilgrims' movement and time permission inside the holy city of Mecca? Last slide. Sorry it took so long. If we look at the way forward that we want to have, I'll just simplify it, make it one sentence. We want to have a public health technology that is equivalent to individualized service technology that we see in hospitals and primary healthcare. In public health, I don't know, it's a big challenge. We need to have it. The world need to have it. I'm 100% sure many countries, they created their own, just like what we did. Many countries have their marketing, or many organizations actually marketing a new product, but we want to have the good one, which looks like the one we have in hospitals and primary care. Thank you very much for listening. I'm sorry I took a little bit long. Thank you.
Dr. Hani, thank you. That was an amazing talk. And to see what Saudi has done in such a short time with technology is really remarkable. So we have a few questions, and I'm going to send two through to you. So the first question is from South Korea, which you referenced in your talk. And they pointed out the remarkable success they've had in control. And one of the features of the technology that they used was akin to geofencing, but somewhat different, where SMS messages were sent to anyone who was going near an area where a case had occurred. And for people in an area where a case was reported, they received a text message. Does your system have that functionality?
I'm not hearing you, but do you mean that like Taba'ud, the one we have where if I share my data so people can see, is that what you were highlighting for?
No, the system in South Korea is a little bit different, so that if you are going to the market and somebody there, there's been cases reported there, you get a message saying you should be aware not to go to the market, because there's cases of COVID. So do you notify people where there are hotspots?
The hotspot function is a little bit, we thought of it, but some challenges came in around. The business owners were a little bit uncomfortable. They said, we will do all of our exercise or homework to clean the place, make sure that all employees exposed and positive are removed from the service, but not to stop the service in the place. So we left it proactively for them. However, people who were entering, if they have a red light in their Tawakkalna, the app, they will not be allowed inside there. Even employees. If I'm an employee in a supermarket and I'm showing my Tawakkalna app a red color, then I will not be allowed to go into my job. If I'm tested positive, I can't go to my work.
Right.
So we used it on the other way around, similar to South Korea, but on the other way around.
Right. Yeah. Thank you. Another question asks for your opinion in contrasting what's happened in Egypt versus Saudi Arabia. And according to the questioner, the curve in there's still COVID-19 in Saudi Arabia, but Egypt is on the down slope. What accounts for the differences between the two countries? And he or she especially points out that Egypt had a partial lockdown where Saudi Arabia had a complete lockdown. Why do you think the pandemic curves look different between Egypt and Saudi Arabia?
I don't know what was happening in Egypt exactly, but I can tell you what was happening in Saudi Arabia. We in Saudi Arabia, from the beginning, decided that we need to test everybody with symptom and every contact. So we worked night and day to provide extremely easy access to testing. We have 100,000 testing capacity every day. Because it is very easy, we never hit that number. Our numbers is around on the average of 60 to 70,000 per day, but we have a capacity of 100,000. So we have an excellent space for testing people and access to care. That will automatically reflect on the number of cases countries reporting. The second element is the ICU capacity and ICU utilization. We have dedicated intensive care beds in every hospital. It's a long story, I don't want to start with it, but we started with 25 hospitals, then we grew up in the number of hospitals, then we said that every single hospital in the country should have a certain number of hospitals dedicated for COVID. So, and we never reach the upper limit in these hospitals. So it means that we provide easy care, easy access, and quality of care that make us look that we have a high number of cases, but on the other hand, we have an excellent outcome. Mortality rate in Saudi Arabia, just 3,300 something. And I think we look good in terms of mortality and ICU occupancy rate. So the number of cases is because of the easy access to testing. Anybody can go test anytime and anywhere in the country.
Right. Okay. So one last question. Saudi Arabia went through MERS, which was a terrible experience. How much do you think that experience with MERS and being through that epidemic has prepared you for the response to this pandemic?
Actually, MERS was, when we look at it as a disease, we feel we have a bitter taste. But on the other hand, actually, we learned a lot from MERS. We created our command and control center because of MERS. We created our EOC because of MERS. We created our, there is a certain supply in public health. I don't think many countries have it. A certain strategy for public health supply chain. That's why we have never had an issue with the supplies of PPEs, because we were well prepared. We have a roadmap, so we were able to build up our scalability requirement for PPEs, and we brought and we encouraged local manufacturing. We pushed out our bar way before we get hit by cases, and that all of that was learning from MERS, actually, as a matter of fact.
Great. Well, thank you for an incredibly interesting presentation, and I wish you the very best in your work ahead. The challenge is not yet over, but hearing the preparation and the facilities that you have is really encouraging. So I ask everyone to please join me in thanking Dr. Hani, and thank you for listening to this session.
Thank you very much. Thanks a lot.
Thank you, Dr. Hani and Professor Michael, for such a lavish session. At this point, ladies and gentlemen, we will share with the audience one polling question before a health policy session. So the question is, in your opinion, what could be implemented to enhance the global health policy in fighting against future pandemics? It's an optional to choose multiple answers. So number 1, unified global policy. 2, a higher transparency. 3, further global collaboration. 4, engaging the public during the policy formation process. We have 30 seconds to show the results. So the numbers are close, but we'll go with the last option, engaging the public during the policy formation process, was the majority choice to enhance the global health policy in the fight against future pandemics. Next, we will be discussing more about the topic of health policy and the impact of health policy on pandemics. To do so, it's my pleasure to introduce the Secretary General of the Saudi Health Council, the chair of this session, Dr. Nahar Al-Azmi.
Thank you very much, Liam. Good evening, good afternoon, good morning, our guest participants, and welcome to the Health Policy Session in Riyadh Global Digital Health Summit. I'm very pleased to chair this important session about health policy, and with distinguished speakers and the co-chair of this session, Professor Mahmoud Adel. I want to thank the organizing team of this important summit, specifically Dr. Algnawi and his team in the National Guard Health Affairs for the invitation. And today, we will be discussing the health policy at the national and global level. As you all know that the health policies has a key role in fighting COVID-19. In this session, we will highlight the successful health policies and analyze its impact on the pandemic outcomes. So we will be discussing the prevention and transmission, ensuring adequate infrastructure and workforce capacity, effective provision of health services, financing and governance, and implementing and lifting the lockdown criteria, and measurements to prevent a second wave of the pandemic. I'm very pleased to introduce the co-chair of this session, Professor Mahmoud Adil, who is the public health, the Medical Director of Public Health Scotland, and National Clinical Data and Digital Lead, Royal College of Physicians of Edinburgh, Honorary Professor of Health Intelligence and Service Effectiveness, University of Glasgow. Welcome, Professor Adil. Can we have Professor Adil, if he's... So, until we have Professor Adil join, I'm pleased to introduce the first speaker and the first session in our session today. It's about the impact of health policy on pandemics. Dr. Mike Catchpole, the Chief Scientist, European Center of Disease Prevention and Control. So, Dr. Mike.
Thank you. I hope you can hear me. So let me start by thanking the new chair and the organisers for inviting me to this timely important discussion. I really look forward to the discussions. I've enjoyed the ones I've listened to so far. So let me start. Just waiting for my slides to respond. So I wanted to start by just framing the talk in terms of the most likely types of pandemic. And I've used the framework here, which has been made famous or infamous by Donald Rumsfeld, talking about known knowns, known unknowns, unknown knowns, and unknown unknowns. So the known knowns, clearly COVID-19. We know about it. We know it's currently causing a pandemic. I would put to you that actually we are also in the midst of a more insidious, but ultimately potentially more damaging pandemic, and that is the pandemic of antimicrobial resistance. Another growing threat which could result in a pandemic is that of vaccine hesitancy. In terms of known unknowns, we have pandemic influenza, in as much as we know that it can cause pandemics, we just don't know when it's going to occur. And then we have the unknown knowns, which are typically zoonoses or vector-borne diseases, of which Zika was a good example. These are diseases we know about, but we don't yet recognize that they have the potential to cause pandemics. And then last of all, we have the unknown unknowns, the killer virus from Mars, which is so beloved of some of our media outlets. But perhaps we don't have to look as far as Mars for the unknown unknowns. And the reason I mention these is because whilst for example, COVID, pandemic influenza, and dealing with the threat of vaccine hesitancy, clearly this response and preparation for such pandemics is primarily an issue related to health policy. But if we look at antimicrobial resistance, we look at potential pandemics caused by zoonoses or vector-borne diseases, then actually it's not only health policy that's important that can have an impact. It is agricultural policy, it is environmental policy that can also have an impact. So I just want to keep that in our mind, that health policy is not of itself the only thing we need to consider in terms of how we can actually effectively impact on pandemics. So this slide shows you what I see as the key elements of policy that are important for pandemic prevention, response, control. Health policy must include an element of pandemic planning. Pandemic planning will often be specific to different types of threats. So all countries in the world will have a influenza pandemic plan, but we need to consider the response to other emerging or potentially emerging threats. Looking at issues such as stockpiling of specific pharmaceutical and non-pharmaceutical products to deal with the most likely causes of pandemics. But of course, pandemic response, probably 90% of pandemic response, 80 to 90% of that response in terms of health is related to basic health infrastructure, both clinical infrastructure, service infrastructure, and public health infrastructure. And probably this is the most important aspect of health policy in terms of impact on pandemics. It's the policy that ensures that we have a health systems infrastructure that's able to respond. It's able to respond in terms of diagnostic capacity and competence. It's able to respond in terms of treatment services and capacity of those treatment services. It's able to respond in terms of public health activities such as contact tracing, and it's able to respond in terms of having the information systems that we need in order to track pandemics and understand them in real time. Remembering that we're often dealing with situations that we've never faced before, and there is a desperately important need for information on the fly, so to speak. I'm really pleased to hear in the last presentation the mention of the importance of public health engagement, or in fact that actually that got the top vote. This is an area which I think we're growing to realize is such an important part of health policy in terms of pandemic preparedness. I will come back to that in a little while. And then last but not least, in terms of the pre-pandemic phase, is health policy as it relates to research and innovation. Again, I'm going to come back to that, particularly when we think about things like antimicrobial resistance. But if we also look at the current COVID response, one of the things that we have struggled with since the outset is despite influenza pandemics, pandemics of other respiratory infectious diseases, as we went into this pandemic, still the evidence base on the relative effectiveness of different non-pharmaceutical interventions, whether they be physical distancing, the use of face masks, was unclear. The evidence base was weak. Now that is fortunately growing with time, but really research and innovation are crucial to ensuring pandemic response. And I see that as part of health policy. Now, during the pandemic, we need to ensure that our health policy ensures not only ensures that we can respond appropriately. I'll come back to the issue of appropriate response, but just to make the point here, again, giving the broader context of this summit, that one of the things we need is rapid, as I mentioned before, rapid flow of information. We need pipelines that will provide the information we need to make decisions. But not only that, but we need to have a priori of identified the triggers, what information will result in a change in the way we respond. And I'll talk about that in a little while. Health communication, of course, we need to have clear policy on who will communicate, how to communicate, what channels will be used. The world is very different from when I started out in infectious disease epidemiology and response and control in the UK. Social media was something that we'd never known about, but now channels like that become increasingly important. And pandemics, by their very definition, are global. And effective and efficient response to pandemics also needs to be global. And so it's really important that we look not only at national health policy, but as our chair said, international health policy, if we're to be effective in responding to pandemics. And then finally, in terms of health policy, we've looked at health policy in the pre-pandemic phase, health policy as it relates to the acute response, and then in the post-pandemic phase, our health policy needs to recognize the need to modify our preparedness plans, modify our response plans in the light of what we've learned from ongoing pandemics. And so if we put, apologies, there's a slight delay when I press the button, but in essence, the areas that, the ways in which health policy impacts on pandemics is in terms of prepare, respond, and reflect. Now, I'd like to just go into a bit more detail on some of these points in the next few slides. Preparedness, the cost of not doing it. You see here some slides from the World Economic Forum, from the Guardian newspaper, from the WHO that really make the point that actually the cost of dealing with a pandemic is many times larger than the cost of actually potentially preventing it, or at least preparing for it better. And there is a huge tendency to discount heavily the potential future savings compared to the costs of the prevention activity or the activity required to prepare for those prevention activities. And I think that this COVID, in the COVID pandemic, we've seen the value of investing in both public health and clinical infrastructure. So the response in China, the speed with which, once the full nature of COVID-19 had been recognized, the speed with which actually it was controlled within China. A large part of that was the ability, the capacity to rapidly mobilize a public health workforce to undertake contact tracing. That is a public health capacity that is not uniform across the world. And then if I look closer to my base, that's Europe, the EU, then clearly, if we just take a couple of examples, Germany and Norway, their capacity to actually roll out and ramp up diagnostic testing at a faster pace than perhaps some other countries, I think was instrumental to their ability to actually rapidly control the rising tide of COVID cases. So again, that investment in ensuring they have laboratory capacity paid significant dividends in terms of their ability to save lives, reduce costs. And I think that whilst in many areas of the world, or world of activity of industry, there's a just-in-time ethic. I think that in terms when we think about pandemics, just in time, particularly when we think about supplies of critical diagnostic reagents, and we think of supplies of personal protective equipment, those supply lines might be disrupted, will be disrupted by pandemics. And so their just-in-time mentality does not work when we think about health policy, particularly in terms of prevention of pandemics. And I would argue that actually building surge capacity into our health and public health systems shouldn't be seen as a cost, it should be seen as an investment. And keeping to the theme of the cost of not doing it, but now thinking more about the issue of innovation and research. This is the World Bank's report. I'm sure many of you will have seen it, where they concluded that the annual reduction in global GDP caused by antimicrobial resistance could be at least as large as the losses provoked by 2008. And I think that given our experience with COVID, it's very easy to see how a major health pandemic can have devastating economic consequences. But they make the point that the cost impacts would be worse than in 2008. And if you look at the bottom of that statement, they also make the point that actually it will lead to greater inequalities across the globe. And we really need to think about how we can invest now to actually prevent things getting worse. There's the need for research into new antibiotics, but probably just as importantly, we need a new funding model. We need a new funding paradigm for antimicrobial development if we're actually to see an acceleration of the development. At the moment, the incentives for the pharmaceutical industry are not great, and we need to think about how we can overcome that. Keeping to the theme of health service infrastructure, resources, and laboratory capacity is critical for infectious disease response. We at ECDC undertake regular evaluations of laboratory capacity across the EU. I think it's really important that when we look at developing capacity in our health policies, there's no room for complacency. We need to continually assess, evaluate our capacities. I think a learning point for us here in 2020 with COVID-19 is that whilst our repeated surveys have demonstrated actually there's a high level of competence within microbiological laboratories within the EU, and that level of competence and capacity is growing. In the early days of the pandemic, we actually lacked capacity for testing, not because the competence wasn't there, but because the supply lines for reagents were compromised by the pandemic itself. And again, that comes back to we really need to think forwards, think about supply lines as part of health policy and pandemic planning. And another issue in terms of health service capacity and infrastructure, I've mentioned several times, but I think it's relevant in the context of this overall summit, is the need for information systems that can deliver high quality information rapidly without overly burdening those who are delivering frontline care. And for me, what that means is we really need to ramp up, we need to invest more in the development of systems that can harness the potential of electronic health records. I know that there are many countries in which that is already relatively well developed, but that's by no means true across the whole of the world. And I think there's still a long way to go in terms of improving our ability to collect data in real time. And certainly my experience from 2009 and the H1N1 pandemic in the UK, but the UK was not unique in this, is that we struggled in the first few months to really define how the severity of H1N1 because of the difficulty of capturing data from hospitals and intensive care units. That's one of the big lessons that was learned, and certainly things have improved remarkably since then, but I would argue that there's still more to be done. Moving on, public and community engagement. I hardly feel I need to say this given the audience vote, but there's a growing recognition of the importance of this. Pandemic response, and COVID is a graphic example of that. Pandemic response often requires that we ask of our citizens, of our fellow citizens, that they actually restrict their daily activities to an extreme event, and we must involve them in making those plans, in sharing with them why we would be likely to ask them to do that. And there's a growing evidence base on that. And again, the organisation I work for, the European Centre for Disease Prevention and Control, recently published some case studies into the value of community engagement in preparedness for emergency response, and provided some guidance on best practice on how to do that. Evidence-based flexibility. This slide's very busy. It's there more to remind me than for you to read, but these are quotes from two important evaluations. In the UK, Dame Deirdre Hine evaluated the UK's response to the 2009 influenza pandemic, and at the bottom a quote from Harvey Steinberg's report on the evaluation preparedness response, WHO's response to the same pandemic. And in both of these, the authors make the point that actually the response to the 2009 pandemic, making sure that the response was proportionate, that the impact of the response, the opportunity costs of response proportionate to the level of threat, was really hampered by, first of all, the lack of timely information on severity of disease. And then secondly, the fact that actually we didn't have clear triggers, a priori defined triggers, for actually when we would decide to upregulate or downregulate response. Clearly, a lot of lessons have been learned from that, but I think it just makes the point that health policy in pandemic situation, health policy needs to be flexible. It needs to have identified a priori what evidence it will need in order to make changes to the level of response. And of course, with COVID-19, we know from a number of modeling studies that have been published over the last few months that the matter of a week or two in when measures are applied can make an enormous difference to the size of the peak that we see, and ultimately the morbidity and mortality and cost associated with a pandemic. And as I mentioned before, it's not just national policy. Much of what I've been talking about, the responsibilities there are national responsibilities, but we need good international health policy. The WHO has a key role in this and has been leading the way for us on COVID. I'm sure we've all heard the oft-repeated phrase that infections do not respect borders, and I think perhaps we've heard it so often that's a danger that we become indifferent through familiarity to that phrase, but it remains just as important as when it was first termed. And certainly in the EU, the European Commission has been working closely with the governments of the member states of the EU in developing joint procurement arrangements so that actually the EU member states can work together in joint procurement for medical countermeasures. And there should be another part to this slide, yeah. And in fact, the European Commission has also created the first ever EU stockpile of medical equipment for dealing with medical emergencies, including pandemic response. And then last but not least, I mentioned the need to learn from pandemics and to shape or reshape policy in the light of those lessons. And I've referred to both of these reviews, but I think they were both excellently written and well thought through evaluations of the 2009 influenza pandemic response. The one on the left you see is the report by Deirdre Hine on the UK response, and the one on the right is the cover page from the evaluation led by Harvey Feinberg into WHO's response. And important lessons have been learned from that, and I'm sure that we will continue to learn. And so, turning now to my last slide, just to remind you, these are what I see as the key elements of health policy that impact on pandemics, and the impact that following, including those elements and thinking about those elements, is that ultimately it will save costs, that actually investing in preparedness now will save significant costs in the future. Investing now will reduce disruption on other health services, on life in the future. Public engagement will secure trust in the population, which is clearly important in sustaining the level and the depth of intervention that continues to be required with COVID. Of course, saving lives, that's the big goal of health policy here, and it's just as important in pandemics as anywhere else. Good health communication can reduce fear in the population. Good preparedness plans, investment in research and innovation can help to reduce inequalities. Learning from the past, hopefully we will actually improve our ability to prevent future pandemics, and ultimately all of this will reduce pandemic impact in so many ways. And with that, I would like to thank you for listening. Thank you again, the organisers, for inviting me, and welcome to, I look forward to joining the discussion after the next presentation. Thank you.
Thank you very much, Dr. Mike Catchpole, for this very informative presentation. And now we will move to our second presentation. the role of digital health in national policy responses to a pandemic by Professor Michael Kidd, who is the Deputy Chief Medical Officer of the Australian Government Department of Health, Professor of Primary Care Reform, the Australian National University. It will be a recorded presentation.
Hello, thank you for the opportunity to join you for the Riyadh Global Digital Health Summit. I'm very pleased to be able to talk to you about digital health and national policy responses to the pandemic. Firstly, my apologies for not joining you live. As you'll appreciate, it's currently the very early hours of the morning in Canberra, in Australia, where I'm based. Making health systems more focused on patients' needs rather than processes is a key theme of the long-term National Health Reform Plan being implemented by the Australian Government. Achieving this requires important shifts in our healthcare practices and our healthcare funding. Digital health, of course, has enormous potential to facilitate these shifts by offering the opportunity of taking healthcare to the individual rather than always expecting the individual to come to healthcare services. Digital health has been growing in Australia for more than a decade, but I think it's fair to say that compared to digitisation of other areas of the economy and society, progress has been slow to date. That's changed, of course, with the need to keep our people safe and to slow the spread of COVID-19. Digital health has now become essential to Australia's response to the pandemic, and at the same time the pandemic has given a huge boost to the use of and acceptance of digital health. Like many countries around the world, Australia had to react quickly as the potential magnitude of this threat from this complex virus became clear. The Australian Government worked with the medical professions, with state and territory governments, and with many other stakeholders to develop a national plan. On the 11th of March 2020, the Prime Minister, the Health Minister and the Chief Medical Officer of Australia announced the $2.4 billion plan to ensure that the nation's health system was well prepared and had the resources needed to fight coronavirus and protect the community. This was the result of intense negotiations and discussions between the national government, the state and territory governments, and leading medical experts and health and professional groups. The package is designed to ensure that the health system has the right tools, the right information, and the right resources to keep Australians safe. One of the goals was to give the health system greater capacity to effectively assess, diagnose and treat people with COVID-19 in a way that minimised spread of the disease in the community. So while at the same time maintaining the capacity of the healthcare system to deal with other health issues to avoid a decline in the population's underlying health status. Two things were essential. Firstly, securing adequate supplies of personal protective equipment to health professionals. And secondly, removing the need for people to travel to a doctor's clinic, to an emergency department and wait in rooms full of other patients and sit close to a doctor when they needed a diagnosis or a prescription. Telehealth offered the potential to deliver on this second requirement. Telehealth has long been recognised in the National Universal Health Funding Scheme of Australia, Medicare, as a valid way of providing health services. But Medicare subsidies prior to COVID-19 were limited to video consultations and primarily targeted to allow people in regional, rural and remote communities to access mental health and specialist care. In November last year, Medicare benefits were extended to regular telehealth consultations with GPs with their patients in remote areas. But with COVID-19 making non-contact medicine highly desirable, it was a logical leap and not such a great leap to turn to telehealth. In a highly pressurised environment, the government consulted with medical organisations to determine what would work best. And the result was that reforms which could have taken 10 years were delivered in 10 weeks. During the pandemic, telephone-only services, in addition to video consultations, have been allowed to ensure universal access. These were introduced as temporary measures due to expire in October, but it's possible they will be retained as a positive legacy from the pandemic. And discussions on this are being held with the medical sector, with consumers and with other experts. There's no doubt that telehealth has now been embraced by both healthcare providers and patients as a core part of our national policy. Since March, more than 22 million services have been delivered by telehealth to more than 9 million patients. On the other hand, any new system usually requires some bedding in, and the Australian Government continues to monitor the telehealth measures and make refinements as needed to ensure the safety, clinical effectiveness and continuity of care. For this reason, additional restrictions were brought into force on the 20th of July. Family doctors, GPs and other medical practitioners can now only provide a telehealth services where they have or their practice has an existing relationship with the patient. And this is designed to promote greater continuity of care, to build the relationship between provider and patient to support better long-term health outcomes. There are some exemptions which include people in areas currently impacted by COVID-19, those in quarantine, children under the age of 12 months, and patients of Aboriginal community-controlled health organisations. And further exemptions will be considered if necessary. The restrictions were designed in consultation with the major medical peaks to ensure that they are meeting the needs of patients and of the providers who are delivering health care to the public. And the impact is being closely monitored, with further exemptions again perhaps being made if they're necessary, with mental health being one area under review. But in the longer term, further improvements may be needed to support widespread use of telehealth in terms of further infrastructure, technology, education of the workforce, and privacy. The other important digital health element in Australia's response to the pandemic to date has been the development and adoption of a mobile phone app called COVID Safe. Early identification of people exposed to the virus so they can be isolated and tested is essential to slowing the spread. The Australian Government Department of Health collaborated with the Digital Transformation Agency and other agencies to develop an app for Australia. COVID Safe uses Bluetooth technology on the mobile phone to look for other devices with the COVID Safe app installed. It takes note of contacts with other users, digital handshakes, by securing and logging their reference code. And these contacts are then stored on the phone for 21 days, which allows for the 14-day incubation period of the virus, plus the time taken in some cases to confirm a positive result. If a person tests positive for COVID-19, with their consent, contact information is uploaded, and state and territory officials can then quickly find other people who also have the app and who may have been exposed to the virus by contact with the person who's been diagnosed. Only users who've been within approximately 1.5 metres of the positive case for a period of 15 minutes or more are identified. The app has been designed with privacy and security as paramount considerations, and downloading and using it is voluntary. Overall, the COVID Safe app is doing what it is intended to do, identifying individuals who've been exposed to risk of COVID-19. None of our states or territories are relying 100% on the app to do the entire job of contact tracing, and in some jurisdictions, public health officials are very adept at finding contacts who've been exposed using other means. But the app has been used more than 300 times by health officials. To give one example, in a recent case where authorities in New South Wales accessed the COVID Safe app data, it showed a previously unknown date where exposure to the virus had occurred at a venue which had been known to have had cases on other dates. This resulted in the identification of an additional 544 contacts, and 2 of those people, when they presented for testing, were confirmed as having COVID-19. While these numbers are small, we've learned that every case of COVID-19 is important. A single person can have the potential to cause an outbreak, and from there, things can escalate very rapidly. The pandemic has disrupted many aspects of our lives, and millions of workers have had to work from home, utilising digital solutions to replace functions normally carried out face-to-face. Many of these workers and their employers would previously have considered out-of-office work either impossible or undesirable. But many workers and employers have continued remote work, at least part-time, even though the immediate health threat in their parts of the country has since lifted. And the same has been seen with digital health. The pandemic has caused a terrible toll, but in this regard, it has been a creative disruptor. It's quite possible that the huge increases in the use of digital health and acceptance of mobile phone apps for public health purposes will provide a lasting benefit. No response is perfect, and I don't pretend that everything has always gone to plan in Australia. We continue to learn about this virus as the pandemic progresses, and we will continue to apply those learnings and evidence as it evolves. As we all know, nothing about the pandemic is static. Thank you for the opportunity to be with you today, and thank you for the opportunity to present some of the findings from Australia.
Thank you very much, Dr. Michael Kidd and Dr. Mike Catchpole. And now I'll just move the floor to the co-chair of the session, Professor Mahmoud Adel. Professor Mahmoud.
Thank you, Dr. Nahar. It's a privilege to be with you and to support on this session as the co-chair. And I'm also grateful to the organizers to make me as one of the member of the advisory board. So it's a very well thought through conference, and it was really excellent to listen to those two speakers. And we have got this particular topic, health policy, is pivotal, because we know that almost every government or every organizations do have some health policies, but pandemic has tested them out, how effective they have been. So it will be really good to pick up some questions, and subsequently I can have my views on this.
Okay, so now we will thank you, Professor Adel, and we'll go to the questions, and probably I will start with this question from Ben Anthony in Gange. What opportunities will emerge out of the current crisis and eventual recovery for transforming healthcare policies? Probably I'll direct this to Dr. Mike and Professor Adel if you want to reflect on that.
Well, thank you for the question. I mean, I think that we can see that we learned enormously from the experience of the 2009 H1N1 pandemic. Whilst perhaps not a pandemic, I think we learned lessons also from the Zika experience emerging out of South America. And I have every confidence that we will learn again. In terms of the specifics with COVID, I think the need for the collection of good quality clinical information that will allow us to assess the impact of different interventions is going to be crucial. And I'm sure that we will see further investment in healthcare information systems over the next few years that will need us to be better prepared for the future. I think the other issue that we need to learn about is I think we need to think about supply lines. Supply lines for diagnostics, for medicines, for personal protective equipment and other things. And I think we need to look at how we can actually prepare better for that. Thank you.
Thank you very much.
I think Dr. Catchpole did highlight a very good couple of points, but one thing I saw from his presentation, he mentioned about the three-way of the post-pandemic reviews. They are very, very important because we need to learn in a very objective manner that what has done well and what went well and what didn't work very well. So I think my question to Dr. Catchpole is that, is there any plan by ECDC that we can do that post-pandemic reviews in a very systematic manner in Europe?
Thank you. Thank you for that question. It's an excellent question, and one I'm very pleased to answer because I've got a good answer. Absolutely. We have actually already published guidance. We've also shared with our colleagues in public health institutes around the EU guidance on current best practice in terms of in-action and after-action reviews for exactly the reasons you say, because I think it is terribly important that we learn from these after-action reviews through the systematic collection of data, so that actually we can pool the lessons from different settings. So we are advocating that. We've actually already been involved in a couple of in-action reviews with EU member states looking at the response. And I would say that ECDC is not itself adverse to reviews, and actually we're in the process of actually commissioning an external evaluation of our own response as well.
Dr. Nahar, would you allow me to expand on this?
Okay, in fact, I just go back to the model where Dr. Mike, elucidated about the pre-pandemic, during, and post, which is the prepare, respond, and reflect, model. In Saudi Arabia, I can just comment on our, response to the pandemic, where we use the, when it comes to policies, proactive policies, reactive, and supportive policies. For example, in the proactive policies, one of the first, decisions was suspending entry for Umrah, and this is, the impact of this policy or this decision was really very, critical, because for people who come to Umrah and Hajj to Saudi Arabia, they are coming from all over the world, and once they leave, if there is any, infection or pandemic, this will definitely have a global, impact. And this decision was one of the first, decisions. Also restricting the movement of the Saudis among the GCC countries. This is even started before, registering the first case in Saudi Arabia. While in the reactive, it's a lot of very aggressive, policies. And in fact, there was a higher policy led by the Minister of Health, and the representation of this committee, where all the healthcare sectors, even the non-healthcare sectors, who come up with a lot of, very relevant recommendations related to the lockdown or the, movement restrictions or whatever. Then it will be submitted to the royal court, and it will be almost approved, in a very short time. So there was a lot of flexibility in providing the policies. Then also the curfew, for all the cities, which happened. And I definitely like the reflection part of the presentation of Dr. Mike about the revision of the preparedness. So all of these are areas of consideration in our revision of improving the policies. Professor Adel, do you have another question? Or?
Yes, thank you. I think it's very interesting and rather very, very important that almost 100,000 people from 110 countries are watching this or listening to this. So the point Dr. Catchpole made, or rather I'm very pleased to hear that that there are in-action and after-action review guidance. And one of the purpose of this G20 summit is that we need to be spreading the best practice. It would be really useful to see that how best we can utilize those resources, and we can share it through this platform. So that is on that point. But I would like to say that when we talk about pandemics and their impact on policies, we need to remember that as health policy is very key for every country. But what a pandemic has done, it has bring some of the things to the front. For example, data and digital, but we were collecting a lot of data. And as Professor Kidd mentioned, in Australia, as well as Dr. Catchpole, that, yes, we need to be collecting more data. And my argument is we need to be collecting more broader determinants of health data, not just the clinical data. Because you look at the pandemic, it is having an impact on many fronts. And unfortunately, many of the health systems, they don't have enough data outside the healthcare setting. And I think in Scotland, we are very proud of that our data is very integrated. And there are a number of other countries who could learn and we can work with.
If I might, Mr. Chairman, I absolutely agree. I think that part of the data gathering, determinant data are incredibly important. I mean, obviously, for chronic diseases, determinants data are essential to our understanding. But if we look at other pandemic potentials, particularly we'll look at zoonoses and vector-borne disease, looking at determinants is terribly important. We know from the experience with Ebola that almost certainly that's being driven in part by changes in land use and deforestation. So determinants is a very broad spectrum of things that we need to collect data on, but I think that bringing that data together with better quality health data will give us incredible insights that will allow us to control pandemics better in the future.
Dr. Nahar, I've got a couple of questions from the audience. Should I ask them?
Okay.
So there's a question from the audience that what are your thoughts on evaluating the International Health Regulation 2005 to improve the international collaboration to revise health policies? Dr. Carpo.
So, I mean, I think that the International Health Regulations 2005 provide an excellent basis for improving collaboration. I mean, in the first place, what they do is they provide a basis for actually ensuring that everybody is operating at the same level, that there is consistency and hopefully therefore interoperability between the types of information and data that we collect, that there is the capacity to detect and respond to problems at the earliest possible stage. So I mean, I think they provide an excellent foundation for that. But clearly, we also need to go beyond that when we look at the full range of different health policies, particularly where we look at, as I say, supply chain issues, standards for health data interchange. But I think that the IHR still provide a good, solid foundation for that.
Thank you. There is another question. Do you think the current national or international health policies are enough to face any future wave or any future pandemic? I know it's very open-ended, very broad question, but it'd be really nice to have your reflections. And of course, the same I may ask Dr. Nahar, that what is the situation in the Kingdom of Saudi Arabia in relation to those health policies?
So just, if I could just ask to repeat, are there policies? I just missed the word after. What are the health policies?
Yeah, I think it's a very generic word, health policies, rather than health protection policies.
Well, I can't profess to be an expert on all health policies in all countries, but certainly within the context of the EU, there has been a general moving together, a general development of increased consistency and interoperability of our member states' preparedness plans driven by EU legislation on cross-border threats. But there's also a committee called the Health Security Committee, where the health administrations of all the EU member states come together on a regular basis and talk about coordination of measures and response. So I think that initiatives like that can really help to improve our ability. And the Health Security Committee is not confined to talking about infectious diseases. I mean, it is, although it does talk primarily about cross-border threats, but cross-border threats are not only infectious. So I'm an optimist. I believe that we learned from 2009. I think that the structures have been put in place since SARS, of course. SARS was a watershed event, really, in terms of investment in organizations like ECDC, like the one I work for, and in developing international legislation that will drive improvements of that. So I'm an optimist, and I think that the answer is yes. I think that health policies are moving in the right direction, certainly from where I sit within the EU.
Thank you. Dr. Nahar, you are in a very key position within the Saudi Health Council. How do you see the direction of such policies in Kingdom of Saudi Arabia?
Thank you, Prof. Adel. In fact, the Saudi Health Council is a regulatory coordination body. The council is chaired by His Excellency the Minister of Health, and the members are the leaders of the healthcare providers and the special regulatory entities in Saudi health system. And in our vision, we are looking for an international standard healthcare system to really reflect on the quality and the safety and the efficiency of the system. Probably you know that the whole system, healthcare system in Saudi Arabia is passing through a very aggressive transformation as part of the Vision 2030 projects. So one of the models which we are seriously looking is the governance model of the Saudi health system. So we know now that we have multiple regulators in the health system which produce multiple policies, and now part of the transformation is moving to less number or even one regulatory body for the health system. But definitely the interest is to move towards more of evidence-based policy, integrating the human behavior towards a healthy lifestyle. The whole system is moving towards a value-based healthcare, which ensure that there will be a higher level of safety, quality, and also efficiency.
Thank you.
Thank you. So I know that probably we are now supposed to finish here at the end of this session. I want to thank you very much, Dr. Mike Catchpole and Dr. Michael Kidd, and also thank you very much, Professor Mahmoud Adel, for co-chairing this session, and thanks also for the organizing team and all the participants who were following this session. Thank you very much, and I'll leave it for the next session. Thank you.
Thank you.
Thank you all for sharing your insights in this rich discussion. At this point, ladies and gentlemen, we will share with the audience the last polling question before our last session, technology and the public. So the question is, in your view, what are the main challenges to the use of digital health technology in changing behaviors during the spread of pandemics? 1, technology adoption and acceptance by the public. 2, technology cost. 3, privacy laws and regulations. 4, technology proliferation, such as the use of smartphones and wearable devices. 5, technology maturity. You have 30 seconds to answer. So the numbers are still close, but we will go with the fourth option, which is technology proliferation, such as the use of smartphones and wearable devices. Or no, the answer is changed. We'll go with the first option, technology adoption and acceptance by the public. The majority chose technology adoption and acceptance by the public as the main challenge to the use of digital health technology in changing behaviors during the spread of pandemics. So for our last session for the day, we will discuss more about technology and the public. To do so, it's my pleasure to introduce the Assistant Professor of Public Health in King Saud University and Centennial Fellow at Harvard T.H. Chan School of Public Health, Dr. Noura Al-Amro.
A very good morning, afternoon, and evening to all of you. I want to welcome you to this final session on technology and the public, part of the Riyadh Global Digital Health Summit 2020, honoring the G20 presidency of Saudi Arabia. It's an honor to chair this session. We have two distinguished speakers. Each one of them will have 20 minutes to present. Then we'll have 15 minutes or so for Q&A at the end of the two presentations. Our first speaker is an associate professor in the Department of Industrial and Systems Engineering at Korea Advanced Institute of Science and Technology. He's a recognized expert in human-computer interaction and social computing. He's also the recipient of many best paper awards, including the IEE Internet of Things Forum, ACM Chi, and many, many others. Please welcome Prof. Yushin Lee, who will be talking about nudging the public to improve compliance.
Okay, thanks a lot for the nice introduction, and it was my great honor to have a chance to talk about this topic. In a pandemic situation like COVID-19, public engagement is critical because we're fighting against invisible virus. We now know that transmission and containment of the coronavirus are mainly depend on human behaviors. When a confirmed case happens, the infected person should be quickly isolated and contact tracing has to be performed to identify those who are in close contact with infected people to prevent further virus spreading. Nonetheless, there could be people without symptoms who can still spread the virus, and to protect from getting and spreading the coronavirus, we're asked to actually, wear face masks and also disinfect surfaces, do not touch the faces, and washing hands. From this, we can actually see that prevention and protection measures are closely related to human behaviors. Unlike prior pandemics, we benefit from recent advances in digital technologies. Mobile wearable devices are widely adopted, and social media, through the social media, people actually spreading information and getting a lot of information as well. And Internet of Things and AI technologies are everywhere, has become an essential part of our lives. And advanced technologies are built upon like big data and cloud computing. During pandemics, digital technologies provide unique opportunities for crisis communications and interactions by helping not only to provide better communicate with the public, but also to empower and engage the public. For prevention and protection, digital technologies play an important role in promoting social distancing, personal hygiene, and contact tracing. Then, how can we actually realize this? Since we're dealing with human behavior, it's important to understand first how human mind and behavior works. According to a psychology theory, human mind consists of two systems, automatic mind and reflective mind. Automatic mind is led by intuition and instinct, covering 95% of our behaviors, whereas reflective mind involves rational thinking, and this is related to slow and effortful decision-making. Since human behaviors are largely led by automatic mind, and surprisingly, people suffer from many kinds of cognitive biases. For example, people value present than the future. Because of these, we tend to make less optimal choices in our daily lives. This, in the end, may lead to bad health outcomes or financial loss. So the concept of nudge is to help people to make better choices by redesigning choices. So this is called the choice architect. And that actually alters people's behavior in a predictable way, which may result in positive outcomes. For example, we can nudge people by guiding our automatic mind. First, we can actually remind people to wear face masks by showing this kind of poster on the door. And also we can have a mask hanger on the front of the door so that people can easily pick up their mask. Flow sign also help people to maintain safe physical distance. It's funny, but we can also even ask people to actually wear a funny hat that constantly remind people of the physical distancing. Also, we can nudge people by persuading reflective mind. Government often send text alerts telling people what to do, what not to do, why they should follow the guidelines. Beyond these simple examples, we can systematically explore a behavioral model for nudge design. First of all, we need physical and cognitive capability for any kind of behavior execution. On the bottom, we see opportunities such as tools, culture, and social relationships. In the middle, we have motivational drives that influence our automatic and reflective mind for behavior execution. This model helps us to actually explore three important dimensions for the nudge design for promoting socially responsible behaviors and technologies. First dimension is whether a nudge targets automatic or reflective minds. The other two dimensions are how transparent it is and how forceful it is. Persuasive nudges are mostly transparent and reflective, such as social distancing and contact tracing campaigns. There are also transparent and behavior nudges, such as social distancing markers and tracking systems. There are also forceful nudges that are widely used to enforce social distancing on a street or to perform admission control to places by checking body temperatures through the thermal scanners. Now let's review how we can actually promote crisis communications and crisis interaction with digital technologies. Digital technologies can be leveraged not only to better communicate with the public for crisis communications, but also to empower and engage the public for crisis interactions. Let's review some examples for crisis communications. This first area of nudge is to address the fact that people tend to interpret a message differently depending on its framing. For example, for lockdown recommendations, we can use pro-social framing like on the screen, stay home, save lives. Responsibility framing emphasizes responsibility by saying it's your duty to stay home. Messages can also emphasize threats to individuals, to families, or to communities. we can make personal framing by saying avoid getting COVID-19. Also, we can have public framing by saying avoid spreading COVID-19. Interestingly, researchers found that public framing is slightly more effective than personal framing. In addition, we can use identity framing. This poster was used in the US to persuade the people in Montana state by saying that we Montanans wear face coverings all the time. There are also other framing methods that utilize speaker credibility, empathy, and social comparisons. Another important nudge for crisis communication is data-driven persuasion with visualization and data storytelling. This is because people want to make informed decisions by better understanding current situations. The COVID-19 information dashboard is the prime example. Many countries use different types of data for visualization, such as simple statistics about newly confirmed cases, death, and recovery cases. This information can be narratively delivered through short videos, as is the case for daily COVID data in motion from Johns Hopkins University. In Asian countries, contact tracing is aggressively done, and they often release infection routes information of the confirmed cases. This infection network from Singapore can effectively visualize the outcome of mass infection outbreaks. In addition, during pandemics, what we see is that we can make use of novel data sources. For example, we can make use of social distancing estimation by analyzing cell phone mobility data. This highlights that we can actively use different data sources for data-driven persuasion. There are several key issues on crisis communication. First, we need better understanding about the technologies, digital technologies. People use personalized media, and interaction with the public is sort of fragmented. Paradoxically, it is increasingly difficult to reach out people in the digital world. That's why for effective crisis communications, we need to aggressively explore in the wild large-scale testing, just as tech giants do. Secondly, data-driven insights should be leveraged. We need a digital transformation of the public services. Fragmented data needs to be actually integrated and processed. New data sources such as cell mobility data and credit card transaction data can be incorporated, and seamless integration of multiple data streams help us to actually do large-scale real-time assessments of the human behaviors. Data visualization and storytelling should be explored. Interactive data visualization tools will help people to actually better explore the data, and these tools could be used to enable data-driven crisis communication interactively as well. For targeted persuasions, data visualization and storytelling can be done at an individual level, but at the same time at the community level as well. Along with the crisis communication, we can also promote crisis interaction with the public using digital technologies. Digital technologies can help empower and engage the public for behavior nudge. Let us first take a look at social distancing. It's quite interesting to see that people have difficulties in estimating distance. According to recent experimentation, what they found is that people overestimate 1 meter and underestimate 2 meters. Keeping safe physical distance is not an easy task at all for many people. But keeping safe distance is even more critical in workplaces, because when infection happens, the facility needs to be shut down for quarantine, which may result in great loss to companies. A number of companies began to adopt smartwatches to nudge workers if they violate the physical distancing. And as Dr. Hajme mentioned about the Amazon Distant Assistant, real-time video data can be also analyzed to track social distancing and allot workers if necessary. For personal hygiene, we also noticed that people tend to underestimate time, or sometimes they forget to wear protective gears. In South Korea, the health authority installed this 30-second singing soap dispenser in a public bathroom. When a user clicks the pump, it starts playing a music for 30 seconds so that it makes sure that people wash their hands for 30 seconds. And also tech companies develop solutions for tracking whether the employees actually wears the face masks or not. Right? So this kind of automatic tracking features can possibly lower the fatigue of the human trackers. Crisis interaction with mobile devices will empower people to use their devices to help contact tracing and early containment. In Korea and New Zealand, QR code scanners are used for people to actually self-check-in the places for the later contact tracing. And Google and Apple Alliance developed a Bluetooth-based API for the mobile contact tracing. So each device broadcasts its signals to the neighboring device, and the device actually records that information in their phone. And later on, when the infection, the confirmed case happens, that ID will be released. That ID will be used to detect whether the person is exposed to the infected person or not, and that alert actually delivered to the user. So mobile application also help people to self-assess the current status and communicate with local health authorities during self-quarantine period as well. There are also several key issues for crisis interaction as well. First of all, there is a concern of digital surveillance. Privacy and security mechanisms must be ensured in any kinds of these kind of technologies. And service providers and authorities should ensure trust and accountability of all these services. And any service surveillance mechanism should be transparent to the public as well. And mobile services should be adopted by the public and in order to be effective. User experience are the key for the adoptions, so that we need to really focus on UX issues. And for effectiveness, critical mass, and also the accuracy guarantee are really required. False positive and negative should be carefully researched before public release. And mobile technology also creates some barriers for the participation due to the cost and digital literacy issues. Finally, for thriving crisis interactions, we must ensure sustainable usage, possibly by building communities, and also the software lifecycle management with continuous improvements is also required. To summarize, during pandemics, I presented that digital technologies provide unique opportunities for crisis communications and interactions. Digital technologies can better communicate with the public by message framing and interaction data visualization. At the same time, we can also help people empower and engage the public for promoting social distancing, personal hygiene, and contact tracing. Thank you for organizing this important event. It was my great honor. Thank you.
Thank you, Prof. Lee. Our next speaker is Mr. Tom Denwood. Mr. Denwood is the Executive Director of Data, Insights, and Statistics at NHS Digital. NHS Digital is the data and technology partner to the NHS in England. NHS Digital has been key to providing tools to citizens, the NHS, open data, as well as data for researchers during the pandemic. Mr. Denwood has an extensive experience in leading major health technology programs over 12 years, the last 8 of which he spent in complex program turnaround scenarios. Mr. Denwood is a transformation expert who helped deliver the Mayor of London's original successful congestion charging schemes, where cars and lorries were charged to drive into central London to reduce congestion and improve air quality. He also worked as a program director to ensure that the London 2012 Olympics was safe and secure. Please welcome Mr. Denwood, who will be talking about the role of national open data strategy in pandemics.
Great, thank you, and good afternoon from where I am. Thank you for inviting me to speak today, and it's a pleasure to support the Kingdom of Saudi Arabia at this conference, and especially in the year of the Kingdom's G20 presidency. I represent NHS Digital, who's been supporting the Kingdom for the last 2 years, providing strategic advice to support the implementation of the Kingdom's Vision 2030 digital health strategy. And if you can see from my sling, I fell off my bicycle and broke my clavicle just last Thursday when I was out cycling with my son. So if you see me wince during the presentation, you'll know why. So I'm covering NHS Digital's response to COVID, open data, and how we've used open data as part of that, and really importantly, protecting citizens' data rights. Because protecting citizens' data rights is something which we're especially strident about at NHS Digital. So even during the pandemic, even through the pandemic, our mandate to operate as an organisation, although it's enshrined within UK law, it really comes, and that mandate really comes from the trust which citizens bestow on us and how we carefully use the data about their care. I'll kick off by talking very briefly about the NHS long-term plan. So in 2018, just a couple of years ago, the taxpayer-funded National Health Service, which we have in the UK, marked its 70th anniversary. And during that anniversary, there was lots of debate about the NHS. And I think if you distill that debate down, there were 3 key truths. That there's a lot of pride in the NHS and its enduring success, which was set up just after World War II, and in the shared social commitment it represents. There was concern about how it be funded, staffed, the increasing health inequalities and pressures from a growing and ageing population. But there was also optimism about the possibilities of continuing medical advances and better outcomes for care. So looking ahead to the NHS's 80th birthday, the NHS long-term plan took those 3 realities as its starting point and tried to take forward what was good about the NHS and its place in the UK's national life, but tackling the pressures and issues it faces head on. And to do that, the NHS long-term plan outlined how the redesign of patient care should be accelerated to future-proof the NHS for the decade ahead. And the plan sets out how it would do that, and its focus was doing the 5 things you see on the screen here around a new service model with more control for the patient and fully integrated health and social care at a local level, better prevention, driving less inequality, more recruitment of staff to fill the vacancies which are had in the NHS and create a better working environment for those staff, improved use of data and digital technologies, and ultimately delivering better value for the taxpayer-funded system. So it was launched in January 2019, and although its themes are still very, very relevant today, and it's the direction of travel and the framework for the NHS in England, it didn't foresee a pandemic, and it didn't mention emergent viruses. So very quickly, NHS Digital. So we are the data and technology partner of the NHS in England. Our job is to make health and care better, and that's why I get out of bed in the morning. And we work across both health and adult social care. and I've included the World Health Organization logo here, is due to our work on international classifications and terminologies such as ICD-10 and 11. We're a WHO designated organization, so we can use their logo where appropriate for a 3-year period. We operate in England because health is a devolved issue in the United Kingdom, with Scotland, Wales and Northern Ireland each having their own approaches to meet their own local priorities for health under the devolved governments. And we are taxpayer funded, mainly by our Department of Health and Social Care, and we employ about 2,500 people and spend about £420 million worth of taxpayers' money each year, and we deliver an awful lot. And in terms of what we deliver, we deliver the critical health digital infrastructure for the NHS in England. And that infrastructure is used every second of every day in the NHS. And whether that's the data fibre network, which the messages pass over, the NHS email service, which is the largest exchange service, Microsoft Exchange service in the world, the NHS data spine, which sends more messages than the UK credit card system, our role in cybersecurity, our role in clinical terminologies and standards, the fact that we're supporting the NHS migrate to cloud and open data and open platform capabilities. And we run many of the national applications, such as the National E-Prescribing and e-Referral and the National NHS app. But most importantly, we manage the most important and sensitive health and care data sets in terms of hospital, inpatient, outpatient and emergency care and outcomes, mental health data, community data and GP record data down at an individual record and patient level. And we manage that so we can provide more powerful and meaningful analytics and act as a platform enabling the rest of the health and care system. But we don't do that alone. We do it in partnership with many bodies, with Public Health England, who led the response to the pandemic, with the new Test and Trace organisation, with NHSX, with local NHS and social care organisations, the innovative technology market in the UK and beyond, some of the eminent universities which exist in England, the care professionals, but most importantly the patients and those who we serve and bestow their trust upon us. So that is who we are as NHS Digital, so hopefully you've got a good feel. In terms of how we responded to COVID, we worked in partnership to respond in 6 main ways. We improved and updated citizen channels. So we run the NHS website, which is the most popular health website in Europe. And we updated all the content. We ran some social media campaigns, and we provided clinically assured content to 300 other micro websites which could use that. And we provided a online symptom checker for the 111 online service. And just putting that live, and it was announced in a Prime Ministerial speech, showed a 90% channel shift from citizens calling 111, the non-urgent call number, to try and get a diagnosis, to then switching to use the online tool. And that 90% channel shift happened instantly. We enabled remote and collaborative care by providing access for clinicians to citizens' shared records, and we busily uploaded and we used the pandemic as a driver to upload 97% of citizens' records in a summary record, so their long-term conditions, medical care are available at their point of care. And we delivered the underlying technology to support the antigen testing service, and we deployed digital infrastructure to help out of hospital antibody testing. But we didn't do the UK tracing app. I'll talk about the 2 green things in a moment, because that's what my presentation's about. And we did enable research and clinical trials. So through our NHS DigiTrials unit, we provided identifiable data into the 12,000 patients who've been recruited into the world famous recovery trial. And this is a randomized controlled trial which identified that the malaria drug, hydroxychloroquine, which Donald Trump mentioned a lot, has no impact on those in intensive care with COVID-19. But actually dexamethasone, a very low-cost steroid drug, does, and saves about 1 in 5 lives of those who are in acute care, in intensive care, and on oxygen. So, and that discovery by the recovery trial meant that both UK prescribing practice was changed the following day, and the World Health Organization changed its prescribing guidelines within a week. And also on the research side, we've delivered a tool which citizens can use in the UK to sign up to be contacted to participate in a COVID vaccine trial, which we're busy mobilising and investing in as a country. So this is how we supported the NHS to respond to COVID-19. And if you wish, you can find more detail by just following the public link there, which has our gold reports of what we've achieved over the last 4 weeks. Now, in terms of open data, and before I talk specifically about COVID-19 open data, a UK reference on open data is the Open Data Institute, which we work very closely with, and we input to their work and vice versa. And it's worth saying that they do have a much wider brief than health. They have a brief across all industries. But founded in 2012, the ODI is an international not-profit organisation based in London. I work on a day-to-day basis with Jenny Tennyson, their chief exec. Sir Nigel Shadbolt is their chairman, and Sir Nigel is one of the UK's most foremost computer scientists at the University of Oxford. And in 2009, the then Prime Minister Gordon Brown appointed both Sir Nigel and Sir Tim Berners-Lee to lead a review of access to public sector information, which they did. And that led to the highly acclaimed data.gov.uk website that now provides a portal to tens of thousands of mainly non-health open data sets. And you'll no doubt be familiar with Sir Tim Berners-Lee, one of the founders of the founding fathers of the internet. So the ODI has a great mission, a great vision and mission, which are worth dwelling on. In terms of the vision, the ODI want a world where data works for everyone, which is absolutely great. But if you unpick data works for everyone, that means does useful and valuable work, and also works for everyone means meets the needs, requirements, and concerns of. So in terms of open data, it must be valuable, but also meet the requirements and concerns of individuals. And also their mission talks about a trustworthy data ecosystem. And trustworthy means both accurate and reliable, but also a system which is worthy of trust by the public. So I think the vision and mission of the ODI are brilliant and very relevant, but it's really worth picking out data that works for everyone and trustworthiness as part of open data. So then if we narrow down to the NHS in England, so we've got a goal that open data is data that's available to everyone, open access, and for those to use and share with three main goals: to improve health and social care, as is the role of our organisation, to inform public debate, and I think to gain trust in the public, you need to inform them. And through our open data, we can inform the dialogue and the public debate on use of data. And it's been great to see citizen epidemiologists during the COVID period really understanding the data and becoming experts in health data, which maybe we wouldn't have expected, certainly back in January and February in the UK. And being able to provide that data and explain it is an absolute key part of our role. And as is speaking truth to power, and making sure that the data is seen and heard by those in elected office and in government. And also our role is to support the innovation and to help develop the UK economy in open data. And so we have about 140 open data releases a year, often tagged to our national statistics or experimental statistics. But during COVID, it's really driven kind of four main types of open data. And this is a public website. You can find our dashboard hub there at the URL at the bottom of the screen. And the four dashboards really produced was the progression dashboard, top left, the coronavirus shielded patient list, bottom left, and I'll be talking about those two in a bit more detail. The NHS Pathways Coronavirus Triage dashboard, and an e-referral dashboard where you can see how the referring rates of family physicians into acute care has dramatically changed pre, during and post the COVID period. So those are the four key dashboards we've produced. I was hoping to do a bit of a live demo, but we didn't think we could quite get the technology to work. So unfortunately, I'll be doing a slide walkthrough, but hopefully you'll be able to pick up the key points. So in terms of the progression dashboard, and it looks really busy, so I'll explain what it is, and then I'll delve into the details a bit more. So I think the dashboard is really cool. It takes the outcomes of those people who've called 999, urgent care number, 111, non-urgent care number, or for those who've gone on to 111 online and ended up with a disposition or an outcome of COVID. But it also considers those who've had a positive lab or commercial swab test result. And the data is very fresh. It's only 3 days in arrears. The reason we have it 3 days in arrears is we find the first two days is very noisy, so having it 3 days in arrears helps that smooth out, and the data is updated daily. So this is an asset which is a Tableau visualization, and Tableau sits on our Amazon Web Services, Databricks data processing platform, data services. So it's pretty cool that we can push out data to the nation, to the public. So this isn't a private dashboard or one just for NHS staff or for directors of public health, which goes out to the public on a daily basis, really detailing the status of COVID around England. And it shows a national position, and you can drill down into local NHS commissioning areas or local government boundaries as well. So if I just kind of talk us through it, at the top here, you can see in the last 7-day rolling period, and the data is accurate as up to the 7th of August. I did the screen grabs a couple of days ago, so that's why it's slightly later than 3 days in arrears. And you can see that in that 7-day period, more than 3 days in arrears, in the 7-day period, you can see we had 20,000 citizens went on 111 online, just under 9,000 calling 111 or 999, giving 29,000 people had a disposition, and there were 4,600 positive tests through either lab tests or commercial swab tests. And you can see in that rather busy diagram, which looks like a smoke cloud, and the smoke is the history of each of the 9 regions of England. And you can go, the darker blobs are where their current situation is. And you can see very clearly there's an outlier, isn't there, right on the right-hand side there. And that's Leicester, which is the city of Leicester, which is in the East Midlands of England, which has had a lot of focus on being a coronavirus hotspot, and mobile testing vans were deployed, and a local lockdown was put in place. So this is the data from Leicester as of the 7th of August. And then just to the right of the diagram of the fade, you can see Leicester at the top, but also the other regions of England and the other local authorities in England, which have the highest number of citizens calling 999, 111, or going on 111 online with the disposition of COVID. On the right-hand side there, you can, in the orange blobs, you can see the positive test results. Obviously very high in Leicester because you surge testing capacity into Leicester, but you can see what the test result was per, I think, 1,000 of the population for the other cities as well. Not surprisingly, those local authorities, a lot of them in the north of England, a lot of them are ex-industrial areas where the housing's more close together, and that really helps the local directors of public health really focus their assets in intervening where they need to on a national basis. And we provide a more granular version of this to local authority directors of public health, and they have 2-factor authentication, and they can look down to an individual postcode level to respond. And citizens can go and see what's happening in their area. And what I've done on the next slide here is just pull out both London and the East Midlands, and again you can still see Leicester prominent there. And now I'm going to move on to the second of the 2 dashboards I'm going to talk about, which is the shielded patient list. So the shielded list, and I'm just checking I'm not overrunning, the shielded list was a request by the Chief Medical Officer to provide a way of advising a subset of the population, those who are clinically extremely vulnerable, to be able to shield. And those who shielded were those who've had solid organ transplants, with specific cancers, with severe respiratory conditions, rare diseases, who are undergoing immunosuppressant therapies, and those who are pregnant, for example. And the data was routinely, the shielded list was created from routinely collected national data initially to create the shielded list. And that list had originally about 1 million citizens on it as at late March when it was first created. And over time, we enabled family physicians or GP practices to add to it, hospitals and other organisations to add to it. And as it stood at its 19th release, so we've got through 19 releases, it had approximately 2.2 million citizens on it. And the government used that shielded list to write to the citizens to ask them to stay at home, to limit social contact and to receive food deliveries. And the government also used that shielded list to provide local councils, so the local councils could provide more targeted services like food programs and enable supermarkets to offer priority food slots to those shielding. And there was an inherently a massive interest in shielding because it had a profound impact on over 2 million citizens' lives. So we had to be very, very transparent in our approach. And we published the risk criteria, we published the algorithm, we published the timing and the known issues with the shielding list. We published guidance for general practice for hospitals, for other organisations, as well as a transparency notice under GDPR. And all of that was about building trust with citizens in the efficacy of the shielded list, and that helped it land more appropriately in the system, enabled citizens to have trust in what we and government were doing. But through that, we found that there was a very big demand for open data relating to shielding, whether it's the emerging vaccine clinical trials wanted to know where they should consider targeting their resources from other researchers, from the media and citizens. So we responded to the demand by creating this, which you see in front of you, which is the shielded patient list open data set. This is the website. Very careful at the front. If you're a patient, please use the NHS website to get your advice. Or if you're already on the list and you've got questions, please go to the government website where you can get extra support. But if you scroll down the list, scroll down the web page, you can see that there's a map of England showing each of the NHS commissioning areas and the percentage shielding by region. And at the top with those two blue bars, you can see the split by age and by gender, and you can see of the 55,977,000 citizens to 2,230,000 were shielding, which is just under 4% of the population. We were very, very clear on what the shielding list does include and what it excludes and what it doesn't include. And again, being very clear and transparent around that is that's important to build confidence in those who are using the asset. And just finally, in this, just drilling down to one area, which is the northwest of England, which has a lot of local lockdowns happening at the moment. And you can see the most darkest blue area, and that's actually Liverpool commissioning group with a bit of water just to the left of that being the Mersey. And so Liverpool, a very old industrial area, an up and coming city now, but that had one of the highest lists of those citizens shielding in England. So I'll just move on very quickly. I'm conscious of time. I think I've just got a couple more minutes left. That the way we protected citizens' data rights was enshrined within the UK law, which is critical during the pandemic. We didn't let standards slip. We absolutely followed the letter and the intent of the law. So by the 17th of March, we at NHS Digital had a full legal framework to work within. So we had some public health directions, and we also used the control of patient information notice, which required us to share data for purposes of urgent public health and for dealing with communicable diseases. So we had the right legal framework, and both of those stemmed from either previous acts of government or previous regulations, which we could draw down on. And also, we were dealing with, we were working with our devolved nations of Scotland, Wales, and Northern Ireland. So we had some Section 255 requests from each of those. So we had a legal framework to work with each of our home countries as well. But my final slide is about protecting citizens' data rights and how, from the outset, we needed to ensure that we maintained an absolute rigorous approach to protecting citizens' data rights, as maintaining and preserving public and patient trust is critical to sharing data during the pandemic and after the pandemic for vital care, for monitoring, for surveillance, for planning and research purposes. And we're very lucky in holding such a valuable national asset in the health and care data, and our ability to use that appropriately has been key in the system-wide response. So specifically, we rigorously worked within our directions and our COPI, the COPI framework, to be solution-focused and operate at pace. We did that while making sure that the appropriate safeguards in place with data accuracy, making sure the data was as accurate as it could be. It was minimised, and that minimisation was necessary and proportional. And we take the cybersecurity of the data, given the heightened risk profile during COVID, we absolutely really made sure that cybersecurity and data security was at the front end of our minds. Whenever we published data, we did a data privacy impact assessment, which weighed up the risks of releasing the data versus not. We ran fast track approvals, and we were very, very transparent in what we did, both on the new data we collected, the analysis we conducted, and the disseminations of the publications we made. On the new collections, we published a unified register, which is available for public members of the public to go and view. And in terms of what we released, again, we have a monthly register which citizens can go and view and see exactly who we released the data for, on what legal basis, and the type of data we released. And we did this by communicating also with some of our key partners, with the National Data Guardian for Health and Social Care, which is an individual who has a statutory footing to ensure that data is used appropriately in the NHS in England, with Information Commissioner, and the Understanding Patient Data information asset, which is a great facility funded by the Wellcome Trust. You can Google Understanding Patient Data, and it's a really great resource of the language of using citizens' data and the language that citizens understand, with case studies, all to help build some capabilities to improve better communication of use of patients' data. So this overview I've given you hasn't been about gathering data in, gathering open data and giving it to commercial AI partners or Cambridge Analytica or large foreign companies. It's been about careful and speedy use of that data in NHS data stores, building trust openly and within a clear legal framework. So just to conclude my presentation, we published key open data to support citizens, the media and others understand the response to the pandemic, and so they could respond to the pandemic. I think we did that thoughtfully and quickly within our legal framework. And if I just have one message, and it's about having an open and democratic conversation and a partnership with the public and with individuals as to the value and uses of data about their care, and that standards can be maintained even during a pandemic. So thank you very much for listening, and I look forward to working with my colleagues to take any questions. Thank you.
So thank you, Mr. Denwood. And on behalf of Riyadh Global Digital Health Summit, we wish you a speedy recovery. And as expected, after such stimulating presentations, we have a few questions. And let me start with Mr. Denwood. You spoke about the open data, and we're interested in knowing, getting the answer for this question. Are the members of the public and media actually using the data that you produce?
Yes, they are. How can we tell? It's easy to say. How can we tell that? By the simple metrics around page views and the number of local newspapers, our media trawler, which are quoting them as sources of their news stories. But also, I guess, really importantly, is around particularly on the progression dashboard, the fact that the two-factor authentication version is used directly by regional directors of public health to respond to the pandemic and call in new services or initiate local lockdowns, and we can see through their use of the progression dashboard. Absolutely the day-to-day use of it. So that's how we measure. And yes, both the public and journalists are using the sources.
Thank you. A question for Prof. Lee. You mentioned the data-driven insights for crisis communication. Can you talk about some examples, please?
Oh yeah, so I think that one of the interesting applications for the data-driven insight for the crisis communication would be, say, analyzing social distancing practice. So some of the panel members already mentioned about the measuring population-wide social distancing behavior. So for example, every cell phone providers, they have for billing purposes, they collect cell mobility data. So you have your cell phone, you're associating with the cell towers, that records is always there. So you can actually start analyzing this kind of data to understand how the entire population is actually moving around. So that information can be actually used along with your policies. So say that you have policies about the new recommendation to the public, and through this data in real time that you can actually see what's going on. At the same time, you can also use that information to inform public to see that these are what's going on. make sure that people try to better persuade people through the data. So that's one interesting application that we can think of.
Lovely. This question for both of you. Although I think it's more for Prof. Lee, but I would love to hear Mr. Dunwood also thoughts on it. You showed us the experience, Prof. Lee. Are there any other governments that are working on nudging?
Well, I think that many countries have been working on nudging, and some of the countries have the specific teams for nudging. I think that Tom knows much better than me. I think that in UK there is a behavior insight team. It's called BIT. When I actually went to their web pages, and they've been doing a lot of interesting projects. And they do controlled experimentations, and before rolling out some of the crisis communication, they do thorough data-driven validation before they do that. So Tom, do you want to comment on that?
That's right, yeah. So there's the behavioural insights team, which are part of the Cabinet Office in central government. And they've, over the last kind of 2 or 3 years, really driven kind of nudge techniques across government departments to kind of instill kind of government transformation. I think specifically within COVID, I can talk more broadly, maybe not directly about the nudge unit, but the behavioural response for citizens has been one of the things which has been really considered, I guess, by all governments, and particularly the government in the UK. And I know it's the SAGE, the Academic Advisory Committee into the Prime Minister and the ministers consider kind of behavioural papers and behavioural responses as part of the overall decision making. So yes and yes in summary.
Great. So there's a question that we received from the participants just now. One of the public health challenges is misinformation. And they want to know your thoughts on how we can use technology to combat misinformation during pandemics.
Mm-hmm.
Properly.
So I think one of the ways that we can deal with this misinformation is that so one of the ways that we can different countries have different sets of information, and one of my colleagues in KAIST, she is actually an expert in misinformation propagation. What she found was that some of the misinformation actually propagates later in different countries. So I think that from the global perspective, that just collecting all this kind of misinformation and having a global registry of this misinformation, so that having a sharing network, so that we can deal with misinformation as early as possible, and through the different channels that we can reach out more people, so that we can deal with some of the worst case scenario. Tom, do you want to add something?
Yeah, absolutely. Yeah. So I guess dealing with the misinformation is, first off, you've got to provide very clear, authoritative information for people to gravitate to and access in the first place, and and make sure that's unambiguous. So in the NHS, obviously with the NHS website and the 111 non-urgent call number, which are the very unambiguous sources of information if you're a citizen. And then just an example from the UK, where the Cabinet Office actually stood up a team specifically to respond to and take down misinformation around COVID, which wasn't helpful. So working with social media companies to dynamically take down sources of misinformation.
Thank you. So we've seen throughout today's session, including ours, multiple examples of mobile apps in different countries. And this question is for Prof. Lee. We know that those apps can be used to engage the public, but how can we persuade them to actually use it?
That's a really good question. So we clearly know the benefit, but in order for it to be really beneficial, then people need to actually install this application. So what I notice from the literature and human behavior is that when people try to actually decide whether they adopt this technology or not, often the time they do actually do cost benefit analysis. So if they think that it can be beneficial, then they will actually willing to actually install the application. But at the hindsight, like if there is certain cost, maybe it's the cost of the the user experiences, it drains the battery too much, then they think that the cost is too much, and then they stop using the application. And another cost aspect may be something related to the accuracy aspect. So, for example, like if you're using the contact tracing, then you have to think about accuracy, whether it has false positive and false negative, and if it is too many errors, then it's really hard to actually convince other people about that, because like in the end they will actually sacrifice their privacy, and they're willing to actually sacrifice their privacy, but for what? I mean, if it is not accurate at all, then why should I contribute? So these are all a lot of the issues that not only the technology, but user experiences. At the same time, some of the privacy concerns related to that. At the same time, the benefit. So I think that these are all satisfied, so that the people are engaged with the application, so that they're actually really beneficial to the entire community.
Mr. Denver, anything on mobile apps and your experience?
Yeah, so I was just nodding at Professor Lee's point around, citizens need to have confidence in how the data is going to be used, where it's going to be stored, who will have access to it, and the security of their privacy. And I think that's absolutely one of the key determining factors in whether someone is persuaded to use an app or not.
I think the last question is for Mr. Denwood, is around legal frameworks. This is great. We've seen the experience. People think that it's just, collecting data, organizing it, and presenting it, but that's it. Can you speak to the legal underpinning of all the experience that you presented today?
Right, you saved the best question till last there, haven't you? Legal frameworks. So I guess I did actually cover some of that in my presentation around the use of legal directions, and those were that kind of legal instrument was set up by the Health and Social Care Act 2012 in England and Wales, and the use of the COPI regulations, which were envisaged that they may need to be used. I think it was back in 2005 they were put in place. So we were very clear that we were working within a clear kind of legal framework around what we do. I think that's important for citizens to want to know that the governments which they elect or work with, are following the law of the land. So we're very clear. We work with the legal framework. We make sure that the data is not disclosive in terms of open data, small numbers suppressed. That we have a disclosure committee to make sure that the data isn't inappropriate for what we want to use it for, and we have extensive cybersecurity testing before we put any of those open data dashboards live, including kind of third parties coming in and helping us test them. And all of that is ultimately about building citizen trust, and that the data about their care will be used in a trustworthy and appropriate way.
Thank you. Thank you both for such stimulating and interesting presentations. Your Excellencies, distinguished guests, ladies and gentlemen, digital health is here to stay. This might be obvious to say, but the truth is adoption of digital health was far from the mainstream till COVID-19, which brought it back to the spotlight, and for good reasons, as we've seen in today's session. We've seen how digital technologies change the landscape of nudging the public by novel ways of communication and interaction. We've seen also the experience of the NHS in England in using open data to keep the public informed, the impressive dashboard, and also how this is enabled by a policy and legal framework. I would like to thank the Riyadh Global Digital Health Summit Chair, Organizing Committee, for their efforts, the speakers for their impressive presentations, and also the participants for their valuable questions and discussion afterward. Thank you all.
Thank you, Dr. Noura. Thank you all for such a rich discussion on the role of national open data strategy in pandemics. Ladies and gentlemen, with this, we have come to the end of today's program of the Riyadh Global Digital Health Summit. Thank you all for your presence and participation. See you tomorrow. We have a very exciting program starting at 2 p.m. and ending at 6 p.m. with the final and vocal point of the summit, the Riyadh Declaration. See you tomorrow.